Good afternoon, everyone, and welcome to this meeting of the Leicestershire Health and Wellbeing Board. This meeting is being broadcast live via YouTube, and it will be archived so you can view it afterwards. We'll move to item 1, which is the appointment of the chairman. You're asked to note that as the Council's lead member for health, I've been appointed chairman of the Health and Wellbeing Board for the period ending with the date of the annual general meeting of the council in May 2025. We move on to apologies. I've received apologies from Ed de Coverley, Jane Moore, John Wilson, Carolyn Trevidic, Councillor Cheryl Cashmore and Sarah Prima, with Rashna Vyas attending in place of Caroline. Don't think Nikki is here yet, but Nikki Collins is expected in place of Jane, and Tracy is here in place of John. Item 2, the minutes, these pages 3 to 8. I propose that the minutes of the meeting held on the 29th of February 2024 are taken as read, confirmed and signed. We're all in agreement? Yes, thank you. Item 3, urgent items, there are none. Item 4, are there any members wishing to declare any interest in respect of items on the agenda? No? Thank you. Item 5 is my position statement. A copy has been emailed to you and is also published on the council's website. I'll just quickly run through because there's quite a lot of positive information in there. I will say that adult social care services are continuing to face high demand with complex presentations, but I'm really pleased that the Home First and the pressures are being managed well. And there's been positive inroads into the number of people waiting for assessments. I do think we all have to work towards as our people who work in the care service being valued for what they do, and also to look to their personal development so that they have progression. It's really important. They do a really important job for the community, and I think we need to acknowledge that. Some really good news with numbers through the NHS. Good to see the appointments available have been increased. I think it's fair to say we need to work on consistency across the county. And great, so many of the pharmacies have taken up Pharmacy First. And I think one of our roles is to actually get that message out to residents, because if they can go to the pharmacy to get some of the minor ailments sorted, it leaves the appointments free for those who need more care. Great to see the numbers reducing on waits for cancer and the planned care. Obviously, we still have quite high numbers on waiting lists, but there's been a lot of work done on that, so good to see. And I just wanted to highlight public health in this report because there's been a number of services that have been highlighted at regional and national that were being done, especially the Health in All Policies work, which has been seen as the most comprehensive process and package ever seen in a local authority. I think that's something we really ought to celebrate. And thanks to Comms for the website, microsite, for all the work that's gone into that. But I also want to put on record my thanks to Victoria, who has done all the work behind the scenes and has been doing a lot of work with all the subgroups. So thank you, Victoria. And I'll leave it at that. You have some of the things I've attended on the bottom of that. Has anybody got any questions on that? Yes, Miss Radford.
I haven't got a question. I just said it highlights within your report on the adult social care how working together we can come to positive actions and that. And I do know within the county that public health and the adults and the children's section are working very closely together, and we are seeing some improvements, you know, not detrimental to each department, but we're working together to improve everything.
Yeah, I think it's important we recognise that. We talk about working together across partnerships, but we also all need to work in partnership within our organisations as well. So thanks for highlighting that. And we'll move on to item 6. I've got a 6A and a 6B. 6A is the Better Care Fund Guidance 2024-25, which is pages 9 to 38. This report provides information regarding the draft Leicestershire Better Care Fund plan for 24-25, and Lisa Carter, the Integration Service Manager at the County Council, will present this report. Over to you, Lisa.
Thanks. I'm actually going to, Tracy's going to do it on behalf of John, and I'm going to step in if she needs any support.
Fine.
If you've got any questions on the intricacies.
Thank you. Sorry, Tracy.
No worries. So the purpose of the report is for information for the Health and Wellbeing Board regarding the draft Leicestershire Better Care Fund BCF plan for 24-25. The recommendations are as follows. It's recommended that the Health and Wellbeing Board notes the Leicestershire BCF plan and the planning template for 24-25. And note that the action that will be taken by the Chief Executive of the County Council following the consultation of the Chairperson of the Health and Wellbeing Board to approve the Better Care Fund Year 24-25 report and use its powers of delegation to approve this for the NHS England submission deadline of the 10th of June 2024. In respect of policy frameworks and previous decisions, I don't propose to take the board through all of those. But what I will highlight is that the 23-25 plan was submitted in June 2023, with the final version coming to the Health and Wellbeing Board in February 2024. However, the 24-25 planning, there is a requirement to refresh this with a revised template. The report confirms the allocated spend in table 20, paragraph 22 of this report. Furthermore, the Integration Executive has seen a draft of this at its April meeting. So regarding timetable, the Better Care Fund Plan 23-25 was submitted to NHSE on the 27th of June 2023, prior to the submission date of June the 28th, 2023. The 24-25 plan will be submitted to the NHSE for submission on the deadline, as I've stated, on the 10th of June. Background, the sections 11 through 13 details the background to the Better Care Fund, which is included for information. Regarding the Better Care Fund plan for 24-25, I'd like to refer you to Appendix A, which is a spreadsheet for completion as part of the 24-25 planning and contains tabs on the following: capacity and demand, income, expenditure, narrative updates, metrics, and planner requirements. The Better Care Fund national conditions are set out in paragraphs, paragraph 16 through 19. And in respect to the strategic narrative, there's no requirement to submit a strategic narrative. This is taken from the 23-25 submission. However, there is a tab in the appendix for updates to this that are relevant for the years 24 and 25. Better Care Fund income for 24-25. The Better Care Fund totals 82.5 million, and there's a breakdown of the contributions again at table 22. So the metrics for 24-25, one metric has been removed. This is the Ashkoff indicator for the number of people that remain at home 91 days post-discharge into reablement. This is due to changing the way that this data is recorded nationally through SALT returns in adult social care. The remaining metrics are the same, but with revised targets as outlined in table paragraph 25. The demand and capacity model, for the refresh on the demand and capacity model, this has now been completed in full with Leicestershire Partnership Trust therapy data inputted as part of the final report to be signed off by the Chief Executive of the County Council. In relation to underspend and activity, updated spend and activity, similarly to demand and capacity, the spend and activity data has now been inputted into the final version of submission, and this includes items listed at paragraph 30 below, and it's incomplete at the time of the publication of this report, so these will be able to take you through those additional elements, or I could talk you through those as well. So that's the overview of the report. Are there any questions for myself or Lisa?
Yes, Rashna.
Thank you. So first of all, thank you for the inordinate amount of work that goes into not only the template completion, but the inordinate number of services that we've got that are funded through this for our population. Just a couple of points of clarity before submission, please. It still says Andy Williams as Chief Executive of the IC. We will need to change some of those, please. And I know you just mentioned it, Tracy, but just checking the data that's required from community therapy. In the paper, it says we need it in time for the deadline. Have we had that, or do you need any support in that?
So I double checked. Because we had to do a 23-25 submission, we kept the names of the people that approved it at the time. So I double checked, and I've changed that now to Caroline, and I've put yourself down as the other ICB lead, if that's okay, Rachna. And yes, we've received all the LPT data, and that's now been fed into all of the reablement and rehabilitation lines for demand capacity. And that's also been shared with City and Rutland, and I've done a template, a table that calculates their proportion of that, because it comes in as LLR data, and we need to divide that by the 3 health and wellbeing boards. So they should have that for consistency, and it pre-calculates it for them.
I think, just for clarification, that data wasn't with us at the time of writing this report, so it will be included.
Any other questions? No? We're being asked to note the Leicestershire BCF Plan 24-25 planning template, and to note the action that will be taken by the Chief Executive of the Leicestershire County Council following consultation with myself as Chair of the Health and Wellbeing Board to approve the BCF 24-25 report and use his delegated powers to approve for the NHSE submission deadline of the 10th of June 2024. Are we all okay with that? I should say we have tried to match the dates so that we can do it through the Health and Wellbeing Board, and it's not possible, so we have to do it this way. But thank you very much for all the work on that. We now move to item 6B, the Better Care Fund year end 23-24. This is on pages 39 to 66, and this report sets out the year end performance for the Better Care Fund programme into 2023-24. And is it Lisa or Tracy? Tracy. Tracy will present the report.
So thank you, everybody. So the purpose of the report is to provide the Health and Wellbeing Board with the year-end performance reporting for the Better Care Fund BCF programme for 23-24. The report also seeks the approval of the submission for the year-end template, which sets out income, expenditure, performance against the metrics, successes and challenges, and statements as to whether the national conditions have been met. The recommendations regarding the report, it is recommended that this board notes the performance against the Better Care Fund outcomes metrics and the positive progress made in relation to transforming health and care pathways in 23-24 be noted. The year-end BCF 23-24 template is attached as appendix to this report, be approved for submission to NHS England for the 23rd of May submission date, which is the deadline of today. Again, in relation to policy frameworks and previous decisions, I'm not planning to go through the previous policy frameworks. This board has heard those in a number of times, but paragraphs 4 to 7 show the previous reporting for the 23-24 plans. In relation to background, just to pick on some key elements of this, on 24th of April 24, the National BCF team published the year-end template for reporting the position of the 23-24 financial year, which requires approval by the Health and Wellbeing Board. This template requires submission by today and will be forwarded to NHS England after approval from today's Health and Wellbeing Board. The completion of the year-end template is attached at Appendix A to this report, and the NHSE submission deadline, as I've stated, is of today. The template consists of tabs that update progress against the following national conditions and whether these have been met, metrics and confidence gained to meeting targets. Some year-end data has not been published nationally. Income and expenditure, demand and capacity, and feedback against overall performance. As stated, I'm not proposing to go through the national conditions for 23-24, but they're outlined in paragraphs 15 to 18 of this report. The table at paragraph 19 shows the targets and actuals at the latest national submission of data, includes an update as to whether these are currently on target, off target, and any supporting commentary. So following on, the 23-24 BCF totals 75.7 million, and the breakdown of contributions is outlined in paragraph 21 of this report. The disabled facilities grant spend has now been included in the template for submission, but again was not available at the time of publication of this report. The districts and boroughs have reported an overspend against allocations for 23-24. However, this is offset by reserves held in previous financial year. Would you like a verbal update in respect of those elements related to the districts?
If you, just a short one, please.
I can do that. So the reason nationally we have a contribution of DFGs that we passport to each of the district councils, and then what we do as part of this year-end report is we collate how much has been spent and for how many DFGs, so the productivity of that spend. So we've had that since this report was published, and I can just go through the list of what those contributions, allocations and outturn looks like. So for Blaby, it was 681,000 and they've spent 881,000. For Charwood, 934,500 and they spent 747,000. Harborough Borough Council is 516,700 and their outturn was 547,995, so just shy of 548. Hinkley and Bosworth was 589,000 and they had an outturn of 682,000. Melton had an allocation of 334.4 thousand and their outturn was 362,000. Northwest was 786,500 and they had an outturn of 607,500, and Obi and Wigston was 460,000 and they had an outturn of 474,600. So that gave us an overall outturn of just over 5 million and the allocation was 4.8 million. But that's not an unprecedented situation. Often what happens with DFGs is that some are started, some are completed, some are billed, some aren't. It's very difficult, especially if you've got DFGs that are extensions of high cost values. So some might get billed in years, some might have started and not billed until the previous year. So it doesn't mean necessarily that we've got any concerns in that overspending.
Okay, that's brilliant. Yeah, thank you. Any questions, anyone? Oh, sorry, you want to come back, Tracy?
Just a couple of other things just to finalise the report off, basically. Demand and capacity modelling, again, for the year-end update on demand and capacity modelling. This has now been completed, again, with the full submission of LPT therapy data, inputted as final report for submission today. And that's the report concluded.
Thank you, Tracy. Any questions? Yes, Councillor Coleman.
Is that the one to press?
Yes, that's right.
Thank you, Chair. Thank you for the figures. If somebody needs a grant or applies for a grant or thinks they're entitled, how long does it take from you receiving something until somebody actually going to see them and able to assess it?
So that's probably an answer for Lightbulb. In terms of assessment, we passport money at the very beginning of each year. As soon as we get it from central government, it's passported directly to you for that spend in that year, in that 12-month financial period. So you get the money in each district straight away. It's going to be June this year, so it's going to be in a couple of weeks' time. And then it depends on what it is that's being requested. So level access showers and stair lifts, particularly at the moment, you're getting somewhere between 2 and 4 weeks, as I remember from the last Lightbulb performance report. Level access showers a little bit longer, around 8 weeks. Anything over that, so you're talking downstairs extensions, etc., can take up to 6 months, and children's can also take quite a bit longer as well. But all of that information is available in Lightbulb performance reporting. Doesn't come into the BCF reporting. All we report on is the numbers that you've completed, because they ask for the numbers of beneficiaries against DFGs.
Rashna?
Thank you. So pertains to both this paper and the previous paper, particularly on the rates of emergency admissions and emergency hospital admissions due to falls in people aged 65 or over. We're obviously quite far off the specific targets. So just in relationship to the 25-26 BCF now, are we taking into account the public health information, the population health information that we've got that suggests that after COVID, we've had a 20% increase in frailty, and therefore some of those numbers that are nationally derived using national data sets perhaps are not right for our population? I just wonder, Lisa, if you could just update on whether we're taking some of that into account for the planning in the future, please.
Yeah, so when we get the population data, so some of the population data for the year lags behind. So what Philippa does from Mids and Lanc CSU is we have to do a bit of a kind of position based on previous population data, which might not include an increase in frailty in the particularly over 65 population. When you look down at the actual figures and numbers, we have had fewer people go into hospital due to falls, for example, than we did have last year. I think it's not by many, but it's still a reduction, which actually, when you think about if the population frailty is increasing, we've actually improved our performance. But because it's a standardised rate against a certain population that's kind of nationally published, doesn't always work in our favour. So what we try and do in the background is have some of that information that goes in as part of the narrative. So as part of the narrative, I've put in there, these are our actual numbers. So you can see we are reducing the amount of people, but when you put that against the population data, it looks like we've done worse against what was the previous target. But you're absolutely right. That is because we've got more people who are older, more people who are frail. And the same applies for the admissions as well. So it's a standardised rate. It depends on what they publish as the population data at the time. This is actually lagging behind by a couple of quarters at the moment, so we tend to put in whatever they've published on the Futures website as the latest data. But rest assured, we do actually keep an eye on that, and we do programme our targets for next year based on sort of our local numbers, if you like, where we are actually performing slightly better.
Okay, you want to come back?
Thank you, Lisa. So just an offer of support, really. We've got an awful lot of information in the risk stratification model that would help us to inform much more local targets based on this. So if we can link up outside, more than happy to support in that.
That would be absolutely brilliant. And I think if we can reflect that and say, you know, here's what we get as national data for these metrics, but actually we know year on year we are improving, then that would be really, really helpful for narrative purposes and consistency.
Thank you, Rashna. Yes.
Rachna, there's also work that's been completed under a range of schemes. So what we'll do is pick that up outside the meeting with you. So caretaking care homes, for example, around frequent fallers.
Yeah, I think it's important we get as much information in from all partners. Thank you. Any other questions? Oh, yes, Mike.
Yeah, it was on a similar vein. I was actually thinking about the in that table, whatever it is, paragraph 19, the 2% ones. I think I'll sort of ask the same question at IE. You know, it looks like we've just missed it, and I'm looking at the percentage thinking, I bet that's about one person. So it's a bit like the falls one somewhere, if not in Health and Wellbeing Board, but in IE, it'd be good to get a sense of absolute numbers, just so we have in that particular case, a sort of almost a kind of downplaying or putting into context the absolute adriftness, if that's a proper word, that we are against target. And then actually, although standardised rates are really important, just actually understanding we are doing more for people who've had a fall. Again, it would just give reassurance that we're at least on the activity, if not the comparator bit.
Yeah, and you're absolutely right. And for, you know, you can be 0.4% off target. So what are the parameters for that? But, you know, we're looking at people who are discharged to their normal place of residence, that's 92%. We're playing next year with very tiny bits of target because you're never going to be 100%. And so, you know, what's that look like? And if we're top quartile in some things, we are playing with a really already strong performance. But funny you should mention that. When we've got a presentation earlier on the work of the IE, I think, if I remember correctly, some of that falls data is reflected in that presentation. So you'll be able to see the actual flat numbers and the difference. If not, I can dig it out.
Okay. Thank you. So we're asked to note the performance against the BCF outcomes metrics and the positive progress made in transforming health and care pathways in 23-24. Also to approve the year-end BCF 23-24 template appended to the report for submission to NHS England by the submission deadline of the 23rd of May, which is today. Are we all happy to do that? Thank you. Thank you, Lisa and Tracy. Item 7, our next report is the Adult Mental Health Joint Strategic Needs Assessment. This is on pages 67 to 254. The report provides a summary of the headlines, conclusions and recommendations arising from the recent Joint Strategic Needs Assessment chapter on the mental health of Leicestershire adults. We have Hannah Blackledge, Lead Public Health Analyst, will present the item, supported by Fiona Grant, Consultant in Public Health. And I believe we have a PowerPoint presentation.
Something is okay, brilliant. Hopefully it will all work. Thank you. So yes, thank you very much, Chair. Just want to from the start sort of acknowledge the help and support from the public health colleagues and the mental health subgroup, which was consulted in the process. Sorry, let me just write on. Yeah. Brilliant. Okay, so probably doesn't need to a reminder here, but the JSNA is a continuous process. Normally takes about 3 years to support the local strategy development, and over the years has developed into different formats. Some of them are chapters like this one, some are dashboards which provide a bit more up-to-date information. And the last report for mental health for adults was in 2019. And obviously since then, a lot has happened, including the pandemic response, which sort of slowed down the process quite substantially. And there was also a lot of developments on the mental health strategy and policy nationally and locally. So in this presentation, I'll try to keep it to 10 minutes and just present sort of the headlines and by exception, where we are exceptional rather than showing all the figures. So in terms of this this cycle, we have formed back in mid-2023 a working group with public health. And started off by doing a sort of extensive data survey and data refresh from the previous report, and went with these data to the Leicestershire Mental Health Place-Based Group as a consulting group on this JSNA. And basically, there were sort of 2 rounds of this consultation. First was presenting them basically with epidemiological health needs assessment and service data. And then the second round was with the full report, including the services and policy sections as well. So in terms of data covered, obviously these are sort of standard approach with epidemiological needs assessment, demography, high-risk groups, and individual groups of conditions. Impacts, we have sections on services, and it's all wrapping up in needs, identify needs gaps in provision and recommendations. We have, in terms of just analysis alone, we're basically going down to about district level data, being aware that a lot more is needed in terms of more neighbourhood approach, but
that will come out in the recommendations. So one of the standard sections on JSNA is basically a question who's at risk, and that covers the demographics, population growth, basically factors in that play a role in mental health and well-being. We've looked a little bit more detail at crime rates, which seem to be going up. And both from the sort of what cropped up, basically, it's although it's still under 30, but numbers of people sleeping rough seem to be picking up last year. There is potentially a high number of people with severe multiple disadvantage, which is people who are homeless, mental health conditions, substance misuse, and also crime. So although this is an estimate, potentially it is a population that maybe needs a more careful look, and a number of I refer you to the documents for description of the general groups. Again, doesn't probably need reminding that we've got a big sort of population growth issues, particularly in older populations, and expected growth by 32 is by 70,000 people overall. And also from our estimates of multimorbidity, it is likely that about 20,000 more people will have 3 or more conditions, one of which can be mental health. Even if it is just physical, there are impacts on mental health as well. So again, demographic growth is probably in terms of numbers quite significant. So in terms of epidemiology, we did do extensive estimates for various mental health conditions, going down to individual conditions using current population and adult psychiatric morbidity survey. Just to explain here that a lot of these estimates are estimates, they're adjusted for age and sex, but they're not actually counted. It's not a counted prevalence, but gives us a ballpark figure for the problems. We've looked at registration rates with general practices, access rates to mental health services, hospital admission rates, and basically this epidemiology part is looking through the sort of comparative lens to national. So whatever I'm talking around here is by definition they're significantly worse than national. So in terms of an estimate of common mental disorders, we estimated about 99,000 of adults. In 2017, 78,000 would have depression and dementia. This is on talking therapies, just as comparison in terms of talking therapies access rates, which is below the target actually, but that's only 13,000 people actually are in contact with services of that number estimated. In terms of dementia, it is actually below the numbers registered with GPs are only about 6,000 against 10,000 adults estimated, and that's a national operation target as well. There is lowest demands for memory services, and in the news recently, neurodevelopment and conditions nationally there are big waiting lists for that. But it doesn't seem to be, it seems to be okay in Leicestershire with everything is sort of, these waiting times are compliant with the NICE. Severe mental illness, 15,000 estimated, 6,000 registered as of December 2023. So, and the registration rates per population are also lower than the national average. And the other point why there seems to be a gap is that 7,500 people with SMI access community mental health services. So there is definitely 7,500 rather than 6,000 registered. There are problems with outcomes in this group, and the one identified was cancer mortality. And on the we don't necessarily know that it's breast cancer, but the breast cancer screening rates in this group of patients is people is much lower than in general, 31% only. So less than a third of women get screened. And full health checks are also lower than. In terms of suicide and self-harm, we still have 50-60 suicide per year on average. Although admission rate for self-harm are lower than the national average. And again, from the estimates from the survey, we could expect about 40,000 adults with a lifetime self-harm or suicidal thoughts history. So potential pool of people at risk. We have a section on impacts. The one thing that cropped up was the big employment gap between those in contact with mental health services and general population. And these people also are less likely, actually, probably half or even less than that, to be in stable and appropriate accommodation. That's a standard national indicator. That was both of them are for 21-22, so could have improved since then, but that was what was available at the time. We look a bit at COVID-19 and sort of have a section on return on investment, which is particularly good for early intervention and psychosis. We have a section on services, both in terms of what these services are, who's providing them, what are commissioning arrangements, short of being a sort of the full directory of services. It's an outline and further details are available. But we were particularly looking at what has changed since 2019, basically. So moving on to needs, gaps and recommendations. A little bit I've actually spoken before, so demographics, the problems of rural deprivation, these local crime rates probably need a slightly, particularly because it's particular violence against person. It's very localized, but the rates are increasing. Also, what's interesting, some of these indicate, for example, we know that the mental health problems among students have increased quite sharply in the last few years, and there's little local information about it. Increased community perinatal services are increased demand, and again this SMD group, which potentially is a quite large number of people. A lot of it emerges from the health needs assessment. Some of these identified needs are here as a result of comments from the group in a consultation. So for example, flexible. That's why we're calling it perceived lack of flexible mental health outreach for people who sleep rough. And we know there's slight uptick in the numbers as well. So yes, in particular, the general feedback from the group was that a lot of this stuff is happening at a neighbourhood level and requires a little bit more insight. And yes, we're highlighting the gaps between people registered with services and those who are estimated to be in the community for both particularly dementia, severe mental illness, and premature mortality. Breast cancer screening, as spoken about, and physical health checks. From other needs of, yes, I mean, I've spoken about those, so I won't repeat that, but there's also that a general perception that diagnosed, both nationally and locally, that the diagnosis of mental illness is happening a bit too late. So better. There is a need for better coordination between children's services and adults. So in terms of recommendations, draw on those findings and again, social isolation, and we are calling for a little bit more of modelling on mental health needs, particularly the demographic change and multiple morbidity in the future. Most of recommendations are about enhancing local data collection, particularly at the neighbourhood level, seeking opportunities for prevention and early detection, rising awareness, and also exploring opportunities for developing flexible mental health outreach for people who sleep rough. And I think I've covered most. And breast cancer screening, improving the update of breast cancer screening. I'm sort of happy to say that the work on that has already started. Physical health checks, awareness of an access to effective treatments for personality disorders, which was also one of the perceived gaps from as feedback from the group. Improving access to mental health services, particularly with these gaps in registration and access to services, as highlighted before. In transition from I sort of didn't go too much detail, but all this is available both in the main document and the report itself. So next steps, we presenting it today to the board, and the next step would be to drive forward the recommendations using either current governance structures or working groups that will be needed. Breast screening, as I said, work has already started, so that's good news. And probably manage the recommendations through mental health subgroup. Okay, thank you very much.
Thank you, Hannah.
I hope it wasn't too
Fiona, do you want to input anything?
I think maybe just to say to reinforce, as Hannah's outlined, how much mental health subgroup and that quite a wide variety of key stakeholders have been involved in sense checking this at various different developmental stages of the JSNA, and that it feels as if there is that engagement to identifying the needs and taking the work forward as a result of that. And I think as Hannah's flagged up already, some of that work that we identified through the breast cancer, this apparent quite low uptake of breast cancer screening amongst women with SMI compared to the rest of the population is quite, really stands out. So already some work is starting to take place.
Thank you. Could you turn your things off? Thank you. I will say, as we're in a public meeting, that breast screening and any cancer screening really, people have a perception that it's difficult or it's painful or whatever. I can assure you it isn't. There may be a little bit of discomfort, but when you think of the positives and the fact that if there is anything to pick up, it can be picked up early, I would urge everybody to take whatever screening programme comes your way. Thank you. Yes.
Yeah, thanks ever so much for the information. I know that some the team from LPT have been involved in the groups, which is fantastic. Just wanted to offer some further assurance to the board, really, that the SMI checks, so the severe mental illness annual physical health checks, have actually exceeded target this year quite significantly. So that's obviously moved on quite a bit from the data. You did mention about assessment for ADHD being okay in Leicester. It's not. We've got significant waiting times, about 4 years actually for assessment, with over 6,000 people waiting for assessment. So it is quite a significant issue. And some of the other elements that we talked about, so perinatal, that's obviously moved on quite a bit since the data was collected, which is great. And also personality disorder, there's been quite a significant amount of work that's happening on that. It's still an issue, but it is absolutely moving in the right direction. Really happy to see about the outreach for people that are homeless. I think that's so important. And we see that over and over again in terms of some of the presentations from the police. So, yeah, I think it's great, but just off the assurance that some things have moved on and some things have perhaps worsened.
Thank you, Rashna.
So Jean has stolen some of my thunder on the health checks, but really important from an equity perspective across Leicestershire Place. We're also finding people who haven't had a health check for more than 12 months. So it's not so much the making sure that people who've had a health check 1 year come back for the next year. It's finding the people who didn't come in that year. And I think that's really important from an equity perspective. Just two things, Chair, if I may. It's good to know about the cancer screening has started, and that's helpful. But I have got a note here from the Leicestershire Place group of the mental health subgroup who've welcomed the findings of the JSNA and the very practical nature of them, because they can pick them up and directly take them into action, which I think is what the Health and Wellbeing Board would expect to see back in terms of those practical recommendations. And they just asked me to flag, particularly for our student population, some of the online and virtual offers that have been designed by students that we have commissioned across the system, which are proving very, very popular with those students. So all the information is on the Joy platform and on the websites. So they've just asked me to give you a bit of a plug.
Thank you. Mike.
Yeah, thank you, Chair. So there's two points. I think Rachel has picked up the second of them, because I'm more than happy to delegate sort of next steps to the mental health subgroup. But looking at them, there's a range of recommendations in there, some of which are kind of low cost and maybe easy. All of them are hopefully pragmatic, as Rachel was saying. Some look like they're going to cost money and be more complex. So I guess there needs to be a discussion at the mental health subgroup about what's affordable and the kind of timetable to put it in. You know, I don't want to give you 18 recommendations and say come back next week and do them, because I can appreciate some of them might not be that easy. I was going to ask about the services. So I think there was like 2 services early on, one of which I think you said, Hannah, was like low demand for memory services, and the other was admissions for self-harm. And in my mind, I was trying to work out, is this because the services are there and they are not used, or are the services not there in the first place? So for those 2, maybe particularly the memory services, is that lack of demand or lack of supply?
It could be anything, but I think the data are not necessarily the latest, so it might be worth talking to the services themselves as well.
Fiona?
With the memory clinics, we know with dementia diagnosis rates, particularly in the county, they have been lower than we would expect to see, so lower than we see across LLR. And my understanding was, and I know a lot of work's gone into this, it might be slightly changing, was that there's a considerable waiting list as well to be able to access the memory services. So I think it might be a combination of things, of not quite being able to meet demand, but also sort of that sort of quite considerable waiting list. So the services are certainly in place.
Tracy?
I think one of the things that I would say, working with colleagues across health and social care systems, is that we're seeing quite a lot of older adults admitted to hospital with underlying physical health reasons, but it's picked up that they've got significant cognitive impairment on admission to hospital, and they're referred through to services after the discharge from acute. So I think it's probably being missed in some instances as well.
Yes, of course you can.
Yeah, thanks, Tracy. Reminded me of another point. And again, sort of guilty of this when we talked about number of multiple and long-term conditions in the early part of the presentation. I must admit, if I'd have gone, what do you mean by that? I'd have gone multiple physical health conditions. And I think it's a reminder, certainly for me and maybe for us all, that kind of mental health is one of those long-term conditions. And there was probably a whole different session on making certain that mental and physical health get treated kind of at the same time. And what you're saying, Trace, is a really good example of that.
Yeah, I'm not sure how many other partners know, but the Joy app and the Joy, I don't know if that's been shared or whether people understand, because I know a little bit about it, but I wouldn't say I'm fully up to speed. So I don't know if there's some more work that we need to do around that and what benefit is for people to use that information.
Rachel wants to come in on that one.
Very happy to share with Health and Wellbeing Board, and I think it's already on council websites, but we can absolutely share, particularly for you to advocate on behalf of the people.
Thank you. Christine?
I noticed under recommendation 17 about improve the transition from children's services to adults with a focus on prevention and what have you. I think that's probably something the 3 lead members at the county ought to put on an agenda item when the 3 of us meet up, to have a discussion of how we can help or how you think we can help or support you.
I think there's work going on within NHS as well to do more of a transition piece of work between the 2 as well. So I think they recognise. Did you want to come in, Fiona?
Yeah, just to say that
No, you're on. No, you were on.
Oh, sorry. Yeah, just to say that obviously the ICB is already leading on a key piece of work, sort of making that link between children, young people and adults. And I think this was just particularly flagging up the importance of taking that preventative approach throughout the life course, as well as obviously recognising how important that transition phase is. And I think people around the table are well aware of that, but just making sure that we don't forget about that and have that added focus on that transitional phase, which is clearly having an impact into adulthood.
I mean, I do know that we work together quite well, but I think if you've highlighted that there are concerns, I think we just need to make sure what the concerns are and how we can support everything.
I think some of the things that I picked up from there is the discrepancy of how many people are going to talking therapies. And I wonder if we need to look at why that is, because that obviously is there for use. But if we're not getting the numbers going to that, or there's a problem with capacity. I agree about the memory services. And I think a lot of this does highlight that, you know, whenever we look right across LLR, quite often we see deprivation within city, but there is so much within county here that we have to acknowledge and improve on. So I think we really have to take that on board. The employment gap, hopefully the Vanguard or the Workwell system that ICB and local authorities have gone, been in receipt of now, will do something for that, because that's working with people who are at risk of being unemployed or who are having trouble getting back into work. So that's something that's moving forward. The mental health of students, I know we've had some mental health cafes going into some of the universities now, and we obviously run healthy workplaces and first aiders in mental health. So hopefully if we can get into some of the universities, perhaps that will help there as well. And I think it highlights the need to feed back from neighbourhoods into place. We need to have that data coming through. So that's something else. Transition. And I think with all the work that's going on, and I know there's some positive movements, as we've talked about, I think the perception out in the public is still that the access to mental health services is difficult. So we have to bear that in mind when we go through our recommendations, I think. Sorry, that's fine. Gemma.
Thank you. Harsha and I were just looking at the table 4 on page 101, which shows the ethnicity was very low in particular groups. And that's something that we see time and time again, with people trying to access mental health services that don't suit them or fit them. And it's the way, again, how do we promote this to people? How do people think these services are for them? So I think those numbers are very, very low. So it's something that, how do we get people to use the services, and are they the right services for people?
Any further comments? No? Fiona, can I just ask you to turn your mic off? Sorry. So we're asked to support the findings and recommendations of the Mental Health Adults Joint Needs Strategic Needs Assessment chapter and approve them for publication, and to support the relevant strategic leads in taking forward the findings and recommendations of the chapter via activity and commissioning plans, strategies, through partnership working and via the mental health subgroup. Are we all in agreement? Thank you. Item 8 is the healthy weight strategy, pages 255 and 288. This report presents an update to the board on the progress of the implementation of the healthy weight strategy for Leicestershire 2021 to 26. The Health and Wellbeing Board is required to act as sponsor for this work. This report will be presented by Elizabeth Orton, consultant in public health, and supported by Emma Knight, Health and Wellbeing team leader at North West Leicestershire District Council. And there's a PowerPoint presentation for this. Thank you.
Okay, thank you, Chair. And I'll nod Victoria when we're ready to turn pages. So thank you for receiving this paper today. This is to give you an update on what we've been doing as a partnership across Leicestershire with district councils, with NHS colleagues, and across the local authority to support our residents to achieve a healthy weight. The Healthy Weight strategy was approved by Cabinet back in 2021 and runs till 2026. And we know that helping people to achieve a healthy weight, and that's both from underweight and overweight perspectives, that it is important that we look at the environment, that we look at the availability of healthy and nutritious food, and that we look at how we support people to lose weight if they want to, through services, through weight management services. And then we also have a systems leadership approach to make sure that we are all acting in the way, coordinated together to improve the services and environment for our residents. And that's how the strategy is set out. Because it's a complex problem, we're working as a system to address it from a whole systems approach. And so we've set the strategy out into 3 key themes. So one theme is around promoting a healthy weight environment. So working with providers of food, retailers, planning sector, places where food is provided in workplaces, really across the system. And then also looking at how we can support services to achieve a healthy weight. So that's the second theme. So looking at the weight management services which are commissioned across tiers, what we call tiers 1 to 4, and they're commissioned across different organisations. And then also the third theme was around systems leadership. So what can we do as everybody's role to play in supporting access to healthy, nutritious and sustainably grown food. That's the Healthy Weight strategy. So, I can't. So the next slide. So what we're going to do is to just take you through the actions across those 3 themes. And it's worth emphasising that these actions are over and above lots of services and provision that we already commission. So this isn't an exhaustive list of everything that we're doing around healthy weight. It's actions that were chosen to specifically add value by working as a partnership together.
So I'll just run you through now the healthy weight environment theme and the work that's been ongoing in this particular theme. You'll be able to see in the report that there's some case studies that support what we've been doing there, so you can refer to that, but we'll just run through sort of a light touch overview of what's been happening. So we've done a mapping exercise, and this is to look specifically about where our food schemes are and if they're meeting the needs of our residents. And we've looked into where affordable food is across the district. Some of it is in high population areas, such as Loughborough and Colville, and other population areas that are high don't have such good provision. So from that, what we need to do now is look at those gaps and look at a coordinated approach as to how we might look at better provision. And within the report, you'll see that there's some best practice case study there from some work that's gone on in North West Leicestershire. And there's also some work in Melton around how coordination of getting food packages out into rural areas. So it's worth having a look at that. We've done a scoping review as well about health in planning policy and how healthy policy can support a better weight. So one of the actions was to look at how we can tackle takeaways and how many takeaways are within Leicestershire. So North West Leicestershire are running a pilot at the moment, and that was because the planning stage that they are at lent itself to that. And we've actually pulled together a policy that has gone out to consultation. So that's being reviewed, the consultation at the moment, and it will be strength tested by the planning development team and then hopefully put into practice. And consequently, if we'll learn lessons and if it works well, roll that out around the county. And then there's some other, we can't just look at takeaways on their own. So looking at other eating establishments, such as restaurants and so on. And there's been a lot of work done to see nationally what's there to encourage better, healthier choices on menus. So there's a report in there as well. So the next step would be could we in Leicestershire potentially look at putting that into practice?
Then we've looked at the actual food provision within local authority in workplaces, so county council specifically as well, and looked at the cafe, looked at where things are placed, looked at the vending machines, and consequently there is a new contract for the vending machines, and they are considering whether healthy options will go into those. And also through the Healthy Workplaces scheme, there's been some work there, and there's been over 50 surveys completed by workplaces across Leicestershire, and there's flagged up a couple of bits that around about only 16% of employees are getting their 5 a day, and around about 66% are getting the water intake they need. So again, that gives us some data on what actions could be taken next to support that in workplaces. And then finally in this one, we've looked at consultation in further education around what is there to support both colleges and universities. And it was pretty much a desktop exercise, but we now know nationally what guidance is there, what other places such as Wales are delivering, and we've spoken to local colleges as well. So that gives us some information to now work with the teen service to look at how we can move that forward.
Yes, sorry. Yeah, are you working with schools? Because schools now do not teach cooking or anything very well. And if they do, it's very much, well, we can't do this because it might upset somebody, you know. And I know when my granddaughter said, well, they only use couscous or something because that won't upset anybody. And I think, you know, you've got to go out sometimes in the real world. And are you working with the hubs that are in Deborah's department, where families who go along, are you going into them to help them with cooking? Because, you know, a lot of people, and it's a lot more expensive to take these use these takeaways than it is to do proper cooking.
Yeah, so we have, as I said, this isn't,
That's all right.
This isn't an exhaustive list of everything that we're doing. This was additional actions that we took on as part of the strategy. So yes, we are absolutely working with schools. We have the Food for Life programme in schools, and where schools can achieve status to show that they're taking food and nutrition seriously. And that's looking at food across the from the sort of farm to fork across the course, and then teaching children how to cook and understand where food comes from. There are also cookery programs for families that they can learn basic skills and how to cook affordably. And we also we are working with the hubs and with the community kitchens and looking at the whole sort of piece about how we support people to have the skills. We also recognise, though, that many families don't have the equipment and don't have, you know, there's quite a large proportion of families don't have a freezer, for example, so batch cooking and freezing isn't always necessarily an option for some families. So we are kind of looking at that in addition to the work that we're doing with the further education. We felt that further education was a gap because we've done quite a lot of work with schools, but not so much with the colleges and sixth forms. So that's why the focus here was on that group. So in terms of services to support people to maintain or achieve a healthy weight if they feel they need to do that. So really we're looking at the weight management services here. As I alluded to, they're commissioned across different organisations. So tiers 1 and 2 weight management services are commissioned through local government, and then tiers 3 and 4 being bariatric surgery, 3 being complex kind of multidisciplinary services to support people are commissioned through the NHS. And so it's really important, because it's different organisations, that we have good communication across and understand referral pathways. And so in this theme, we looked at we tried to see if we had any gaps in our provision in terms of weight management. And so we felt that perhaps one area that was particularly we didn't want to focus the strategy on obesity. This is a healthy weight strategy, so we're cognizant of children who may be underweight and making sure we had mechanisms of identifying those children, and then also children with learning disabilities and making sure that we were able to cater for families to support those children. And so those were identified as gaps through the work, and so we've done some work around the letters that go to parents through the National Weights and Measures programme to try to make it easier for parents to be put in touch with weight management services. And there are specialist tier 3 services as well, provided by UHL for children who have complex problems. We have also looked at there's a resident survey that goes out through Active Together, our partnership, that look at physical activity, and they've taken some of the qualitative feedback from that survey to give us insights as to how we might, if you like, market or socially market kind of the services that we have. So what are our ways of promoting healthy weight to people? What are the messages that we need to use? How do we appeal to people? And so they've produced an infographic which is provided in the pack, and we'll use the insights from that to inform how we deliver services. And then we've also worked really hard to ensure there's a commissioned pathway across tiers 1 to 4. And so there is a pilot tier 3 adult service, and that's currently, well, it's running, although it's closed at the moment to referrals because there's been so many referrals in the first sort of quarter of its operation. It's pretty much full with its year's quota. So this was a multi-year pilot. But at the moment, they're just trying to focus on the existing clients that they've got in that service and the patients that they've got in that service. So hopefully that will demonstrate that there is good value for money return on investment in delivering a tier 3 service, and there'll be, a view on recurrent funding down the line. But that's where we are at the moment. We also don't do that many bariatric surgeries compared to other areas. So again, I think that will be looked at in due course.
Okay, so just moving on to theme 3. So one of the actions was to be advocate for system-wide healthy conversation skills training. Unfortunately, the current funding has come to an end for that, but what's happened is there's been multiple trainers trained across Leicestershire, which means they can now deliver training to public-facing people across a number of organisations, voluntary sector, local authorities and so on, that will then have the skills to pick up conversations with people and signpost into relevant services. There's been a webinar for primary care delivered, and there's around 300 primary care staff went along to that. So these conversations are being supported in primary care as well. And there's been bespoke healthy weight resources that have been developed, and you can access them through the Making Every Contact Count Healthy Conversation Skills website. So that, again, gives the people that have had this training the ability to signpost effectively. Also within this, it was about identifying gaps in weight management service provision. There was some work done through an organisation called Venna that created boxes similar to those that you might see done by Gusto, but healthier, more specific to the target audience, to ensure that women in post-pregnancy care were getting the right nutrition. There's also health in all policies action. So that's looking at supporting planning decisions and school designs. So that's about having a health impact assessment on new developments, and that's been pulled together through Town and Country Planning Association, Public Health, local planning policy teams and so on, to make sure that that is a robust process that can be taken by developers to make sure that they are delivering the right environments and active environments for the residents. And there's also health in all policy being rolled out within County Council. There's been training which goes across 3 tiers. That means that all cabinet decisions and scrutiny papers would have health in all policy considerations, and as a result, healthy weight would also be considered within those papers and within any new programmes or policies, etc. And then there's been identified within primary care DES plans, which basically are a plan for each primary care network as to what their focus will be. So we know which ones have a focus on obesity, and we work with them to see how we can support that in the local area. So the next steps are to look at, we noticed that when we were looking at the actions, that there's actually quite a bit of overlap sometimes with the systems leadership and the environment and services theme. So we've consolidated into 2 implementation groups that look at
this kind of services and the environment and leadership kind of cuts across both of those. So we're not changing the strategy, we're just changing how we implement, work together to implement the strategy in the coming year. We're also now focusing on the next step actions. So where we've done the mapping to show there are gaps, for example, then it will be the actions will be to actually do something about those gaps and to work across partners to implement programmes where we can, amend programmes, etc. The tier 3 pilot is ongoing, and then there is an evaluation that's concurrent with that. And so as we learn the effectiveness of that programme, we'll be able to look at how it's taken forward, so working with NHS commissioning colleagues. And then, as we said, the DES plans, we're looking at how we can support primary care to make sure there's referrals into the various different types of weight management services and awareness of what's available in terms of physical activity programmes in their local area, and awareness of the county's provision at tier 2. And then finally, we'll be looking at the impact of, for example, the changes to the planning policy and guidance to see how that's having an impact in terms of effectiveness of policy implementation, and then ultimately provision of retail outlets that are healthier options. So I'm happy to take any questions.
Christine.
I admire your about the planning policy, but I do have concerns that, you know, the people who want to do certain things won't then go to appeal. Unless it's a national policy, I'm not quite sure how North West are going to be able to stand up if it doesn't fit the national policy, and whether or not you get on board the planning officers as well. And I mean, ages ago, I did mention when all these new developments were coming up, they ought to have an area where people could sort of like run round the estate, you know, make the pavement a bit bigger, or walk or something like that. But unless the developer comes on board, you don't stand a cat in hell's chance, I'm afraid. I support what you're saying. You know, we don't want these ones near the schools and everything like that. But, you know, the people who are putting in for applications can appeal. And unless you've got the government behind you, you don't stand a chance, I'm afraid.
Oh, had it on. Yeah, we're quite aware that that is the case, and we're quite aware of some appeals that have been completely overturned, especially by these big organisations. KFC is one of those. So we're working quite closely with the Town and Country Planning Association. We are going to test it with our planning development team, because it's obviously gone through the planning policy team so far, to make it as robust as possible. But as you say, the proof will be in the pudding when we actually implement the policy. So in the pudding, sorry, not the best use of words there, was it?
I think it's also important that the pre-application discussions between planners and developers are strongly fought. So that's where the main work goes on before the application stage, isn't it?
I do admire what you're trying to do. I think it's brilliant. We've really got to come down on these developers and what have you. But I just think sometimes anyway.
I think it's fair to say that most people are on board with it across the districts. So perhaps developers have to take note. Rachna.
Thank you. I think it's a little bit about ambition as well, isn't it? The Leicestershire place having an ambition to be a healthier place is one that we should absolutely be pushing. So thank you, colleagues. Really appreciate this. Liz knows I'm a big advocate of this, given that obesity is the base disease for a plethora of diseases that then come up, and linked to Tracy's earlier point, health and social care impact later on in life. So Liz, you're going to expect me to ask this because we've had a conversation multiple times about it. Ultra-processed foods and the link then between that and not only gut health, which we know then has an impact later on in life in dementia and Parkinson's and that kind of organic disease, but also just the impact it has on childhood health, particularly given the year 6 stats we've got in here. Are we going to do anything locally around ultra-processed foods, the literacy around ultra-processed foods and what that means for our population? Because it feels like a bit of a faster win than some of the longer term strategies that we talk about in here.
Yeah, so I think there is, we're going to have to take a multi-pronged approach to this, both in terms of availability of healthy, nutritious food, and also people's kind of how they seek it out, and education and support to cook their own alternative food and not use ultra-processed food. The challenge is it's so cheap, and in a cost of living crisis, then that's the battle that we face. I guess through our approaches through the things like the vendor boxes, so provision of lowering the cost of healthy food or unprocessed food is one of the strategies that you can use. So things like the vendor box reduces the cost, and then also enables the sort of expertise, the cookery skills to be able to then use those products. And then there's reducing availability, which is what the planning work is about. So can we restrict the availability of fast foods and ultra processed foods near, for example, schools, and then also working with those retailers to offer a low salt, fat, sugar option. I think, again, as with tobacco and alcohol, there's big industry, and it's a real challenge to kind of that's the context we're working in, but by working in places like food banks to have a nutritious option rather than necessarily processed food is kind of where we're at. We've got a food plan for Leicestershire, which includes all of these strategies in there. We're looking at nutrition as well as obesity, so they're sort of separate but related issues. And so I think you're right, looking at the nutrition aspects is maybe an area that we can have some more wins, but still the cost of food of unprocessed food is still going to be a challenge.
Yes, Emma.
Just something else on that is you mentioned the year 6 children, is we know that one of the big issues going to and from school is passing the shops. So we are looking at the takeaways and we're looking at the restaurants, but one of the other things we do want to look at is piloting how we can encourage shop owners to reconfigure their shops. We can't stop them from selling chocolate bars and so on, but be a bit more mindful in how they put their stock out, so that it might discourage. Whether that would work or not is a different matter, but it's something for us to look at.
I think it's quite important as well. People steer clear of a lot of the big supermarkets thinking they're very expensive, but a lot of them have actually, on the fruit and veg side, started producing packs that are a lot less expensive. And I think perhaps people haven't realised that. They still think, oh, it's going to be too expensive. But yeah, Mike, you were next.
Yeah, thanks. So not much to add, because I was going to talk about it's really good to see progress being made, particularly on healthy environment. I get the challenges there would be, but I think it's been excellent to get to where we've got to and having a go in a way that before we wouldn't have done. I didn't want to put you on the spot, Emma, because there was a question in my mind about, it's great that North West Leicestershire are doing this and Melton are a bit. Rather than get into a kind of, can you name the districts that aren't? Joe's on the line, and I suppose the thing is I want to make certain that a place-based strategy like this, which is really good, is kind of really plugged into locality-based work, if not directly with districts, then through the community health and wellbeing plans. So to make it a more positive question, have we got that link whereby we're not just kind of going, we're working at place and that's that, but we're really making people in localities know about what's going on and they're influencing the bottom-up plans as well?
Yeah, so I feed back as the district rep to my equivalents, but the health impact assessment stuff has been across all the districts and has been brought in by, I believe, all the planners. So that work is ongoing, and I know there's at least 2 or 3 others that have this in community health and wellbeing plans, either through diabetes, obesity, or similar. So I think there's 3 or 4 districts altogether in that.
Right, yeah, thanks. And that's really interesting. So I guess it is that question then of hooking this work onto what, for a better phrase, tickles the fancy of the community health and wellbeing plan. So it's diabetes. So instead of going healthy weight and they don't really understand what you're on about, if you go diabetes and this is what you can do, then that gives you the extra hook.
Okay. Gerald, did you want to come in? Jeffrey, I mean, sorry. Sorry.
Yeah.
I've had a funny week.
Thank you, Chair. That was absolutely fascinating. I'm particularly interested in your comments relating to future planning and dealing with planning officers. Are the other districts working, and particularly Leicester, which has to be the hive of your working in with it, and has some, rather than invent the wheel, are there policies elsewhere that have actually been brought in which you've found as a success when I speak, fortunately, because I didn't pop into the Golden Arches on the way here. But I'm interested in knowing how you're actually going to get it to work as far as plans are concerned, and who else has done it and where have been successful.
So I probably can't answer your question in full because the person leading on that from the implementation group, it isn't me, but I have been involved in it. So yeah, all planners have been involved in the creation of the health impact assessment tool, which is now being sort of used, practiced on, sort of being put into practice sort of as we speak. In terms of what else has happened there, Jenna, who's leading on it, has done a lot of work at looking what's been going on nationally. So that has been sort of compared. I couldn't tell you exactly what that is, but I'm sure we could perhaps feed that back to you. So yeah, all planners from all districts have been involved, as have Active Together in pulling this together, and Sport England as well to a certain extent, because one of the reps at Active Together also works at Sport England. So it is being pulled together in a way that all districts are bought in. What the sticking point tends to be is where districts are with their local plan. So they're all at different stages. So depending on what stage they're at will depend on how much they've adopted from that so far. I hope that answers your question.
Did you want to come in on that point?
Yeah, it's just, I mean, I think that comes back to the point the chair made in their position statement about the health in all policies work. So yes, Jenna has been working with Liz and with Emma around that and looked at what others are doing. But, you know, it's difficult to blow your own trumpet, but we're getting to the point of being kind of national leaders in this at the moment. And I think it's been recognised nationally for what we're doing. So, you know, it's good. There's good bit of local leadership going on.
As Simon.
Thank you. Excellent paper and presentation. Just building on Rachna's point, really. So we know at UHL we're going to have to invest this financial year and beyond in some of the services that Rachna alluded to, that obesity is the base condition for. So diabetes in particular, we are investing in our type 2 service this year because of the ever increasing demand. Are we confident through this strategy that we'll hopefully readdress where we're putting our resources into the more expensive secondary care end, moving that out into the prevention and the local authority services? And are you confident we've currently got the provision we need in the local authority to prevent the further down expensive spend in our healthcare system? Thank you.
Well, I mean, you know, with 65% of the population overweight or obese, I think we have still a ways to go to kind of say that we've got there in terms of prevention. I think we know what kinds of things work, but there does need to be a national policy as well as local action. We're doing a significant amount of work around breastfeeding in the early years, so and work with schools, so that, you know, in terms of prevention, that's a key area of activity. But we do know that people who have complex or severe obesity, it is quite cost effective to address that, and so that's where the tier 3 and tier 4 bariatric surgery can really help. And we don't have a huge supply. Well, there isn't a huge supply of that at the moment. We know we're not doing as many bariatric surgeries as other areas. So, you know, it has to be both a prevention and a secondary prevention approach, or tertiary prevention. So I'm not confident that yet, until we've got a full pathway that isn't kind of, you know, clogged up, I guess, with demand, that we have got sufficient supply. But it's expensive too, and so, you know, getting that return on investment takes time, and I understand there are pressures across the system. Reduction in obesity will reduce the bill on diabetes, so, you know, and obstetric complications and knee surgeries and hip surgeries. So, you know, it is an area that I think perhaps, you know, it's just it is a whole systems approach, and that's the approach we're taking. Will we ever have enough money or resources in the system? I'm not sure.
Mike.
Yeah. Liz said what I was going to say. I mean, I think the answer for me is, you know, there's many different organisations and levels in prevention. What could the NHS do? Additional money for tiers 1 and 2 in our world would be fantastic, but I think the first thing would be, you know, the tier 3 weight management services, only pilot funded and has been overloaded. Tier 4, as Liz says, we're not doing as much. So the NHS really should, there is a bit of, there's a bit of prevention that they need to do there as well. So first off, make certain that that's covered, then think about what extra there might be, subject to financial limitations.
A whole system approach, as you keep saying, is important. Deborah?
I'm probably going to go back to the war years and the Dig for Britain. So I'm working with a group called Edible Loughborough that is community gardening for communities, and that works really well particularly in areas of deprivation where they're providing free food. Volunteers are looking after sort of mini allotments, and they're using elderly people's or people's mobility problems that can't actually look after the garden. They're taking over their front gardens and using them to grow food. So I think there's prevention, and we're probably going to look at it a bit more for the family hubs in those locations as well. But I think this going back to understanding where food comes from and getting children at early stage and families as well. So is that part of your food plan?
Yes.
Yes, so that's part of the Food for Life programme, but it's also in the food plan to kind of look at community growing, so community allotment schemes, in the health impact assessment, having sufficient allotment allocations in new planning developments is in there, but also it's kind of working with our voluntary sector as well to help, because we don't necessarily have the skills to teach people how to garden, so we need to bring that in. So it's about partnership working. We're really keen that things like gardening are used as an opportunity for people to be more active. So we're not, when we talk about physical activity, we don't just mean kind of playing squash or doing that type of activity. Gardening is really, really good for you, strength and balance, as well as your cardiovascular system. So we have volunteering opportunities to work in parks, country parks. But it is part of the plan.
I think it's important. I mean, I've been to a number of schools, Deborah, where we've had the soil line, and they've actually set up their own growing system, and they have grandparents and parents go in, and they also have the cooks teaching them certain menus. But as you'll remember, we had to transform the service because of budgets. So, we're keeping the foundation going, and then it's up to schools to do it digitally, but it is there. Mike, did you want to come back?
It's just to check with Liz, are we still working with Incredible Edibles then at the moment or not?
Yeah, that was part of the food plan. So over in, so there's a national organisation, and over in Calderdale, they've done a huge amount of work around the sort of vigilante growing. So they're growing carrots in, hedgerows and things, that kind of thing. So we did look at that. I'm not sure we've got a scheme active at the moment. We'd have to check with Gavin on that one.
Okay. Well, that was a good discussion. So we're asked to note the progress to date. So I think there's been quite a lot, and there's quite a lot of actions to take. So thank you very much. The next report, item 9, is the Health Protection Assurance Report, pages 289 to 320. This report relates to the assurance functions of the Leicester, Leicestershire and Rutland Health Protection Assurance Board. These functions are a key element of the Joint Health and Wellbeing Strategy and form an essential element of local health and social care strategies. The report also updates us on health protection performance, key incidents and risks, and other significant matters. The report's being presented by Anuj Patel, Strategic Lead, and Fiona Grant in support. Thank you.
Thank you. So we're bringing the 2023 Health Protection Assurance Report to the Health and Wellbeing Board to provide an overview on the performance, key incidents and other significant matters. The report has been prepared with contribution from key partners across the system to assure the Director of Public Health that appropriate processes are in place to protect the health of the population. The report gives an overview of the 5 strands of health protection, which are outbreaks of communicable disease, including COVID-19, screening programmes, immunisation programmes, healthcare associated infections, preparedness and response to incidents and emergencies. It's worth noting that the local authority does not commission the majority of the services which contribute to the protection of the population's health. However, assurance is sought to ensure that arrangements are robust and meet the needs of Leicestershire's population. The first key aspect of health protection covered in the report is the prevention and control of infectious diseases. The report lists the roles and responsibilities of the agencies that we work with the Director of Public Health holding overall responsibility for the oversight of any incidents or outbreaks. First communicable disease covered in the report is COVID-19, and March 2020 saw the first case of COVID-19 in Leicestershire, which is the same month as the first national lockdown. Director of Public Health produced a local COVID-19 outbreak control and prevention plan to build upon existing response mechanisms. Key partners were invited to meet regularly to ensure that the response was robust and it was well efficiently implemented. There has been a resurgence of measles cases reported in late 2023, the majority of cases identified in the West Midlands, predominantly in Birmingham. Locally, in order to prevent outbreaks, vaccination remains a key priority. The World Health Organization recommend 95% coverage of 2 doses of a measles-containing vaccine, and in England, this is combined with mumps and rubella for the MMR vaccine. The first is given to children when they're aged 12 months old, and the second when they are aged 3 years and 4 months of age. In Leicestershire, estimated coverage for 2 doses at 5 years is over 90%, and that's significantly higher than other areas in the country that have had outbreaks, but work remains ongoing to improve this further. Cases of diphtheria were identified in England in new arrivals. Whilst no cases were identified in Leicestershire, a local group led by the Integrated Care System was established to ensure that at-risk populations could be vaccinated and that local healthcare providers were aware of the evolving situation. The next strand of health protection covered in the report looks at immunisations. Childhood and adolescent immunisation uptake is better in Leicestershire than the England average. This is essential to protect local population. HPV vaccine uptake continues to be a system priority, particularly because of the links between HPV and different types of cancer. It is offered to children when they're aged 12 to 13 years old and is delivered by the school-aged immunisation team. HPV vaccine has now moved to a single-dose vaccine, and we will continue to work to ensure eligible groups able to receive their vaccinations, particularly looking at vulnerable groups. Uptake of seasonal flu vaccine has improved since the COVID-19 pandemic, and performance in Leicestershire is better than the England average. Performance also exceeds the World Health Organization target of 75% coverage. The flu letter for 2024 has also been released now, and will continue to work with a range of providers to ensure that Leicestershire's population can conveniently access flu vaccination. Key priorities for 2024 will be to continue to increase the uptake of MMR vaccine and to maintain uptake of influenza vaccine in high-risk cohorts such as care home residents. Increasing the uptake of HPV amongst both boys and girls, and to reverse the nationally seen downward trend. And also to note that commissioning responsibilities for immunisations will be delegated to ICBs by April 2025. Screening detects conditions within the healthy population who have an increased likelihood of developing a disease. Overall, cervical and breast screening programmes nationally have experienced a downward trend. Locally, Leicestershire has seen a downward trend in these screening areas as well. However, a similar or better than England average performance continues. Bowel screening coverage and uptake rates have increased both locally and nationally. For sexual health, an integrated sexual health service detects, prevents and treats sexually transmitted infections in the local population. From April 2024, the ISHS service provision is being commissioned as an independent service, and Leicestershire maintains the current agreement for another year to the 31st of March 2025, with the longer term service provision to be procured in 2024. An online service has started to offer a range of testing options for sexually transmitted infections and treatment for chlamydia. A sexual health needs assessment was completed in 2023, with several recommendations made around STIs and can be found online. Prevalence of TB, so tuberculosis, prevalence of TB across Leicestershire remains lower than both the England and the East Midlands average. Work will continue to improve BCG vaccination and TB screening eligibility criteria awareness. It has been identified that engaging with non-UK born arrivals at an early stage to encourage participation, screening and vaccination is key. The next part of the report looks at healthcare associated infections. Many healthcare associated infections are preventable. The data is collated by the Integrated Care Board and covers Leicester, Leicestershire and Rutland as a whole. Roles and responsibilities are listed within the report, and a system approach is taken to responding to any HCAIs. The ICB Infection Prevention and Control Team and the local authority IPC team are in the process of sharing educational resources to expand IPC learning access for both general practice and for care home staff. And this includes sessions on C. diff and carbamazepine-resistant organisms. A new IPC community of practice has been convened with relevant stakeholders and is in the process of identifying current system issues and developing and coordinating relevant strategies. The local authority worked with Local Resilience Forum to undertake their annual exercise programmes and to respond to incidents as they arrive. We continue to ensure that partners are clear on the response to major incidents, including roles and responsibilities, regularly reviewing contingency plans, and looking at risks associated with changing weather plans, for example, prolonged periods of hot weather. Finally, the report covers air quality. A lot of work is going into the air quality with the formation of the Air Quality Partnership, and will continue to monitor and consult planning applications that might have a significant impact on air quality across Leicestershire and provide local support and relevant information to encourage sustainable behavioural change and increased understanding of air quality. Just to summarise, the Director of Public Health has been assured that processes are in place to protect the health of the population and will maintain and improve progress on key health protection indicators.
Thank you, Anish. And Mike.
Yeah, if I can just add to that, I really wanted this report to come here. I think if you think about the work of the Health and Wellbeing Board, inevitably there's a lot about system pressures and integrating services and improving health and demand management. And we don't really do justice to the amount of partnership work that there is that goes on about dealing with the threats to our health. Doesn't matter whether they are business as usual, if you like, so dealing with outbreaks, diarrhea and vomiting in care homes, C. diff, whatever. The responses to kind of, if you like, old favourites that have come back, pertussis and measles being there, all the new stuff that crops up, and you know, the COVID would be the prime example. Particularly so at the moment now, the ICB have had the responsibility for EPRR, emergency planning, transferred over from NHS England, so myself and Rachna co-chair the Local Health Resilience Partnership, and then the increased role of the ICB as they pick up the delegation next year around Vacanim under Kay Darby. Again, I think it's almost much more of a kind of localised system response than maybe it was when NHS England was there. So I'm not suggesting we kind of go and take every agenda of the Health and Wellbeing Board and go, scrap what we used to do, let's look at health protection. But I do think there's a role for the Health and Wellbeing Board to at the very least be aware of what's in place in terms of the incidents that are dealt with day by day by ourselves and our partner organisations, but equally just to be assured that we are dealing with it as best we can, accepting there are some things that crop up. And again, COVID's a prime example where however hard you try, you're always going to be in a sticky situation. So, you know, I think it's not just about going, look what we're doing, it is a shared endeavour.
Yeah, thank you. Any other comments? No? Thank you. We're asked to note the Health Protection Annual Report 2023 and recognise the specific health protection issues that have arisen locally, the steps taken to deal with them and the areas of focus for the coming year. All agreed? Thank you. Move on to item 10, which is Leicestershire and Rutland Integrated Care Board End of Life Strategy, pages 321 to 328. This report is to inform the board of the development and next steps of the Leicestershire and Rutland Integrated Care Board Draft Palliative and End of Life Care Strategy 2023-24 to 27-28. Kerry Core, Head of Integration and Transformation at the LLR ICB, will present the report. Thank you.
Thank you and good afternoon, everybody. So the purpose of the report is to inform the Health and Wellbeing Board of the development and next steps of the LLR Integrated Care Board Draft Palliative and End of Life Care Strategy. The recommendation is to receive and note the update on the development of the strategy and the next steps, but to also provide comments and feedback of the draft strategy so we can continue the work that needs to happen and progress going forward. So policy framework has been noted in the report, which is 3 to 5, but it is expected, NHS England do expect all ICBs to produce and publish a palliative and end-of-life care strategy that sets out our key priorities and the actions that will guide and underpin delivery of our responsibilities across LLR. And as an ICS, we have already identified dying well and end-of-life care as a key priority area. So just a little bit of background that's been noted on the report. Both the Health and Wellbeing Partnership and the LLR ICB have adopted the life course approach from the best start in life to dying well, with a commitment to ensure patients have a personalised, comfortable and supported end of life, and are supported with personalised support for carers and their families. Our 3 upper tier local authorities, also known as our places, Leicester City Council, Leicestershire County Council and Rutland County Council, have also worked with partners to develop their respective joint health and wellbeing strategies that focus on certain challenges in each of their areas, and all 3 strategies include a mention to the importance of dying well. And furthermore, all 3 places have updated their respective joint strategic needs assessment in relation to end-of-life care. Just noting the ambitions for palliative and end-of-life care. So this is a national framework for local action, which was developed by a partnership of national organisations across statutory and voluntary sectors. And it sets out the nationally agreed vision to improve end-of-life care through partnership and collaboration action between organisations and at local level. Now, it has been noted in the report that the framework is built upon 6 ambitions, which are areas within the report, with a statement to describe how the ambition in practice is detailed, which is in figure 1. And the ambitions and frameworks are recognised as the agreed national standard to ensure that everybody has the best possible experience of dying, death and bereavement. ICBs are required to undertake the self-assessment in order to identify progress and gaps against the 6 ambitions, and this hasn't been done in isolation just with the ICB. It's been a commitment through the End-of-Life and Palliative Care Task Force, which is supported by every organisation and is represented through Health and Care, our voluntary sector, and people that are supporting our patients and families on a day-to-day basis. So the Palliative and End-of-Life Care Task Force, which reports into the Community Care Partnership, was established post-pandemic to define, plan and deliver a longer-term end-of-life care pathway offer across health and care systems. And that task force absolutely brings system partners to collectively raise, discuss, troubleshoot issues and challenges, and realise opportunities that impact end-of-life care within LLR. So just some progress to date. There was a subgroup that was set up to look at the needs of this strategy, or the draft strategy, and the Palliative and End-of-Life Care Task Force absolutely looked at what was needed and what we needed to do going forward, which then was presented to our Community Care Partnership, and then looks at how we can review and analyse inputs of what we've done so far in terms of the 10 strategic priorities that have been identified and noted in the report, and just some inputs to determine the priorities, and again, recommendations from the JSNAs for end-of-life care, outputs of that ambitions work for palliative and end-of-life care, including that self-assessment framework, but most importantly, existing insights and feedback from our patients, the public, and direct input from clinicians involved in palliative care. Absolutely crucial to note here that it's about people with lived experience. How are we hearing from them? How are we shaping our services, and how do we continue to develop this strategy that will best fit the services that we need to kind of cater for and support those patients and their loved ones when they need that support from us. So the 10 priorities are detailed below in figure 2, which have been highlighted and also show an interdependency with those 6 national ambitions. And those priorities so far have been endorsed by the Palliative and End-of-Life Task Force, the Community Care Partnership, the Health and Wellbeing Partnership, and have synergies with the pledges made in the 5-year forward plan, improving health outcomes in terms of identifying the frailest in our community and wrap care around them, ensuring we deliver the right care at the right time and the right place. So we didn't want certain pieces of work to be delayed, and we have continued to progress this with partners across LLR. So in the last quarter, we have set up work streams to support the implementation of those key interventions for year one, noting that it is a 5-year strategy. And figure 3, detailed in this report, shows what those work streams are, what the interventions are, and how they align to the ambitions with the interdependencies. And the work through those work streams will continue to shape the strategy going forward, but will also shape the work that we need to continue to support and progress in the next year or so. So in terms of stakeholder, patient and public involvement, so the draft strategy has obviously been presented here today for comments and feedback and to note. And we do have a draft engagement plan, comms and engagement plan, which we were starting to work on in the last few weeks, but will now formally have to progress post-election, which will cause a slight delay, but we'll continue to work on certain elements in the background so we can continue to do the work that we need to do. But just to give some reassurance to the board today, the draft strategy so far absolutely has looked at the insights and data generated from previous local patient, carer, staff and public engagement, and that's already influenced the draft strategy to date. The ICB has a history of engagement and involvement with a range of stakeholders. Public and patient participation has been refined over time, with the ICB doing more work to understand the needs of the local population and share their insights, learning and business intelligence as we want to design our offers in terms of end of life and palliative care, but absolutely co-design them with our patients and with the public to ensure that we are doing the right thing by them when we are looking at those services and looking to improve them. We've had key conversations with the voluntary and community sector, including those with lived experience, and that's also influenced the draft strategy to date. We did hold an in-conversation event on the 13th of March on end of life, and it was the event was aimed to share, learn and shape services. The event brought together everyone with an interest in end-of-life care, which included health and care professionals, but most importantly, the voluntary and community sector, patient groups, family carers, professional carers and individuals. And we looked at some of the information that was being presented to us that day and influenced the draft strategy to date to ensure that we were listening and we continue to progress their views and their reflections and how we can continue to improve end-of-life care within LLR. So just noting, as previously stated, there is a draft comms and engagement plan that outlines the activities that we intend to undertake, but this will now progress post-election. But in the background, we will continue to consider some of the work that's already progressed and continue to work with colleagues within the task force and our partnership groups and our place-led groups to continue doing some of the work that we have noted in the report and in the draft strategy. Thank you.
Thank you, Kerry. Can I just check you had the feedback from our Health and Wellbeing Board's development session on end of life?
Checking if it's on. I did, and that has been incorporated in some of our draft strategy information, and we will continue to do that going forward.
Thank you. Mike?
And I can't remember if that's what the feedback was, but I was going to ask, so the stuff that's in paragraph 11 around what's in the system-wide strategy, and then paragraph 14 around what we need to do in the first year, how does that fit with place-based work? Because again, I know you say early on it's kind of reflective in all our things, but I suppose I'm wondering at what stage, say, take the stuff in paragraph 11, it's kind of like system, and I'm just wondering where it then goes into a piece of work that allows for differences between Leicester City and Rutland.
So we have absolutely looked at the community and health wellbeing plans and the priorities that underpin those plans, and where we have got priorities around end of life and palliative care, we are speaking to those place-led teams at local level to ensure that the work that we're doing here is coordinated and supported across those places, across those districts, and our support and the work and the interventions are mapping into those work streams. And also to give some reassurance, the representation in each of those work streams is across LLR, with Leicestershire County representation from the voluntary sector and from the council itself, working through those work streams to then underpin the work that we're doing and the priorities at each place level.
Yeah, Kate. I suppose just making certain that as a place that is the board, we've got a kind of a feed in there as well, because the places, those are, the locality, what I mean? We need to make certain we don't go straight from system to locality and don't get the representation from the place that is Leicestershire, this board essentially.
Yeah, I agree with that, Mike. When you said place group, I don't know which place group you were talking about. So we do need to join the dots just for Health and Wellbeing Board or place. Yes, Tracy.
Thanks, Chair. Kerry, you know that I brought this up previously in respect to figure 2, which is the kind of line 3, which is improved service provision, where gaps are identified, including for bereavement support, anticipatory prescribing and social care offer. It's not just, I think, the social care offer that we need to look at, it's the wider offer in respect of support services for supporting delivery of care and support at end of life. And just a thing that I find that might be contentious in respect of fast track application. The fast track information in respect to the national framework talks about the rapidly deteriorating condition of a person. And yet what we see on a fairly regular basis into my service area is we won't undertake a fast track because the person is still taking on fluid, food, and is conscious. When I've looked at that framework, it doesn't state anything about food, fluid, or consciousness. So I just think we perhaps need to look at that as part of how we address matters relating to end of life, particularly that kind of end stage.
Thanks, Tracy, and all of those points are valid. In terms of some of the work that's happening across LLR and what has happened previously, I think the training and education and the awareness of what we have available and what is in the framework and what can be done through our teams, clinical, non-clinical teams, needs to be strengthened and is absolutely a priority within the strategy itself. But we need to continue to look at what's working, what's not working, reflect on what can be changed, and how do we support our teams on the ground to ensure that we are improving the care for those patients and supporting them as we need to, but also how do we work better together to reduce duplication and have a look at how we can improve our services across health and care, really.
Tracy, are you linked into this fully? Yeah, thank you. Any other comments, questions? No, thank you. So we're asked to note the update on the development of the strategy and the next steps. So thank you, Kerry. Everybody happy? Yes, thank you. Item 11 is the Community Health and Wellbeing Plan update, which is pages 329 to 276. I presume that's 376. The purpose of this report is to provide the Health and Wellbeing Board with an update on the progress of the 7 community health and wellbeing plans across Leicestershire and outline the findings of a lessons learnt exercise recently undertaken. This report will be presented by Jo Clinton, Head of Strategy and Planning for the ICB, who's online. Thank you, Jo.
Thank you. Good afternoon. Yes, so we're asking the board to note the update on the community health and wellbeing plans, and in particular, North West Leicestershire plan has now been approved and has been included as an appendix for the board. So that just leaves us with 2 plans now to develop. So the Harbour plan is progressing really well. They've now agreed their set of priorities, and that will then need to be signed off by Harbour District Council, but we hope to be able to start their partnership board in September. And ODB in Wigston is pretty much following that same timeline. So really pleased with their progress. Yeah, we're also asking you to note a recently completed lessons learned exercise, and we undertook this based on the fact that some of the plans had been live for 12 months, and we wanted to understand, you know, what's working well, what's not working so well, do we need to areas of improvement. So we have an action plan from that, and they can be sort of categorised in 4 key areas. So one is around relationships and partnership working. So there's variances across each of the plans, and that's probably down to the maturity of some of the partnerships that were already existing. Data and information, governance as well. So there was some feedback around governance not being quite clear, around the golden thread between neighbourhoods and place, and then around capacity and resource, which comes as no surprise, but everyone's you know, really busy and about having time to dedicate to the plans. So we've got an action plan in place around those areas. We're also asking the board to note the areas of escalation. As I've just alluded to, one of the areas is around ownership of the plans and how it varies between partnerships and neighbourhoods. But again, that's something that we will work on locally with each of those areas. We're also asking the board to note areas of celebration. So we've certainly seen strengthening of partnerships across each of the areas, particularly with the voluntary sector, which is really good. We've also, for the first time, got a comprehensive set of data that has been collated by a number of partners for that specific neighbourhood, which has been really insightful. And then we've included a bit around this Charnwood celebration event that happened in March, which was a real success. And we've included the link so that members can see the full write-up from that. And then the last thing that we're asking the board to note is that further updates will be provided through the Staying Healthy Partnership update. So that's the partnership we feed into as well, or directly by exception to the board. I'm happy to take any questions.
Thank you, Jo. You actually answered a question I had been given about timeline for the other 2, so that was very prudent. I do have one minor thing. Melton is very good at letting me know the bulletins, etc., that come out. Would it be possible for all the others to be able to do that? Because it gives us a link into what's going on the ground. That would be helpful, thank you. Anybody else have anything to say? No? So we're asked to note the progress of the 7 community health and wellbeing plans with Leicestershire County, note the outcomes of the lessons learned exercise and resultant action plan, note the escalations and celebrations outlined in the report, and note that future updates will be provided via the Staying Healthy Partnership update report or directly by exception. We all agreed? Thank you. Thanks, Jo.
Thank you.
Item 12 is the Staying Healthy Partnership Joint Health and Wellbeing Strategy Progress Update, which is pages 377 to 418. The purpose of this report is to provide an update to the board on the work of the Staying Healthy Partnership in relation to the Joint Health and Wellbeing Strategy 2022 to 32, Staying Healthy, Safe and Well priority. This report will be presented by Mike Sandys, Director of Public Health, and there's a PowerPoint presentation for this. Thank you, Mike.
Yeah, thank you, Chair. In the interest of time, I won't sort of dwell on the slides too long. First off, you can see there's going to be a joint presentation today between me and my other Joint Chair, Ed de Coverley. There was some kind of an announcement later on yesterday which had Ed rapidly giving his apologies and saying he had to attend to business back in NBC. What that was. So you just got me. So the first slide is just about governance. I'm not going to insult your intelligence by kind of pointing out we're one of the 4 subgroups of the Health and Wellbeing Board. I think it's the boxes underneath that are important. a lot of what I was going to cover actually is kind of usefully covered by the healthy weight strategy and the work that we've been doing on that. And I suppose that one just shows there are a range of existing groups, the Chief Housing Officers Group, the Chief Officers Partnership, Cultural Services stuff, etc. Those existing groups where, if you like, they've been working on housing planning and other things, where we've gone out to them and if you like, recognise their role in health improvement that's valuable to the Staying Healthy Partnership. So we haven't gone and set up kind of 7 new or 6 new different groups. We've essentially harnessed what's already there for groups looking at those kind of wider determinants of health and use those as a vehicle to take forward a kind of health conversation. So kind of that's that one. Thank you, Victoria. And then essentially the work of the Staying Healthy Partnership, responsible as we are for the Staying Healthy, Safe and Well life course of the Joint Health and Wellbeing Strategy, is around 2 things, kind of, and they do overlap somewhat. So building strong foundations is one pillar, which I'll go on to, and the other is enabling healthy choices in environments. Underpinned by work on understanding those groups which are more affected by health inequalities, work on wider determinants and work on prevention. And I suppose my reflection would be they're a little bit mashed up, because actually some of the work on building strong foundations and healthy choices is really wider determinants work. So it's not so much underpinning foundations underneath, they're almost like the writing on a stick of rock, if you like. Wider determinants and health inequalities is the writing on a stick of rock that goes through the stick of rocks that are those 2 pillars, if you want to look at it that way around. So next slide, please, Victoria. So a couple of slides on what does building strong foundations look like. And again, this kind of reiterates things what we were looking at earlier on. It's all that kind of healthy public policy stuff. So the health and all policies training that Emma and Liz talked about, that Jenna Parton has taken forward. Plenty of work going on around employment and healthy workplaces. So in addition to our existing public health offer around working with workplaces to improve, doing health MOTs with their workforce and improving their own workforce policies, you'll probably know that across the ICB and ICS, we were successful as being one of the 15 national places recently to be awarded money to be a Work Well Vanguard, joining up that employment and health support between health, local authorities and the Department of Work and Pensions. We've also, obviously, we've been through a kind of painful experience from a public health point of view in terms of the service redesign that we had to make around our own homelessness support. That doesn't put us off working through the housing officers group to look at what we might do around homelessness prevention through the homelessness prevention grant that districts do to consider support for rust sleepers. And then again, in a different world, I suppose, a community safety world, the people zones, a really important initiative around growing safer communities. The role of sport and physical activity in diversionary activity as part of that, I think, is key. So a nice little join up around that one. And then on to the rest of it, again, Anuj referenced the work around air quality and health. And that forms part of the Building Strong Foundations, Staying Healthy Partnership work, again, being channeled through planners and the housing officers, etc. Much in there as well. I won't sort of detail everything in there because hopefully you can read it for yourself. And then I think priority 2, are we next? Yep. Again, Liz referenced, Emma referenced the building healthy environments work around fast food outlets and also alcohol premises. Josh is in the room, so working with our planners around where there is a concentration of alcohol outlets and making representations, if you like, through the planning process around that. Looking to extend that to address gambling harm as well, to again address density of gambling premises within local districts. Going through, redesign of local services, sexual health services to make them more accessible for residents, both in terms of understanding the cohorts of people that use those, but also utilising new technology within that. And I guess if there's one thing we haven't mentioned today is making every contact counts, which is something that's been around forever and a day. but actually has got some traction now in terms of making certain that any interaction between a health and social care professional, or any professional, is always an opportunity to kind of cross-refer and raise awareness with our customers around the services that are provided through a number of different organisations. So if you like, any point of contact is always a teachable moment with people in terms of raising awareness around other conditions they could be helped with. And then if those are the broad brush pillars, when we considered as a partnership the work on health inequalities, we decided to focus on 3 cohorts, one of which was those with a learning disability and autism. One of them was those in temporary accommodation, so not just in homeless hostels, but your kind of sofa surfers. And the other one was around women's health. So a bit like what Liz was saying, you know, we don't try and do everything. There's an awful lot of business as usual that we do. We have had, through the Staying Healthy Partnership, you know, deep dives, if you like, when we've all met as a partnership and considered what's going on in those 3 areas. What is it that we could add value to? So we've done that deep diving. And then what's come out of that is these ones. So for learning disability and autism, been doing further work to, as a multi-agency partnership, promote the take of annual checks for those with a learning disability, because I think we've seen in previous reports today and in other times that the take-up of annual health checks and indeed the health status of those with a learning disability and autism is really not been good. So again, there's multi-agency work to promote that through all our different organisations. There is work going on to strengthen the support offer for those in temporary accommodation, and then women's hubs, you know, were paused for a bit, but now back on. I guess really we've got to the stage of kind of women's health hubs as making certain that we're making the most use of women's health hubs as a vehicle for broader health issues, if you like. There's always a push to make certain that there is a join up there with the other support hubs that are there, particularly around family hubs. And as the box says, it leaves a gap on wider determinants. So if women's hubs as an initiative is brought into place, that's great, but it doesn't go and address the range of everything that would make a difference to women's health. So what we want to do as a Staying Healthy Partnership is make certain that kind of holistic, both service join up, but if you like, the holistic work on health, on women's health, isn't just about a narrowly defined range of issues and services that develop. So we're beginning to think about that too. And then I think in terms of next ups, keep up the momentum on those 3 areas. And I suppose that's about it. So there you go.
Thank you, Mike. That's great. Any comments or questions, Christine?
Yeah, I've got no problem with having a women's section, but I always feel that the men suffer sometimes because they don't come forward if they've got an issue, whereas a woman would go, and it's usually the women in the family that tell the men to get themselves down to the doctors. So what are we doing to make the men be aware that, you know, it's not going to get better if they don't go? You know, they've got to do something about it. So, you know, I'm just wondering where the men come in, because I'm sure the men would turn around and say, well, you know, that's sexist only having a woman's section.
I don't feel in a good position to answer that one. Strangely, many things that are going on. We're trying to make certain men get paid more than women for doing the same amount of work. That, you know, men are more likely to be promoted into good jobs. No, let's not go there. So, what are we? It's a fair point. I mean, again, I suppose in women's health hubs, from a health point of view, it was a particular bit because of the traditional lack of access from women into that. I guess the important thing is maybe pick that up through the health inequalities work. I'm a little bit loath to get into kind of, you end up with work streams for everything. For me, I think the issues around why don't men attend, say cancer screening would be an easy one. You know what the issues are. If you're out at work, you're driving a lorry, you're never going to go to your GP to go and do it. And there's, you know, there are kind of generic issues around the pressures of work and when a service is put on, and cultural barriers to taking up screening programs, whether you're male or female. You know, those ones are fairly generic. And I wonder to some extent how much this is about women's health hubs are there for a particular thing. Let's make certain we do that well, but then pick up barriers to access, whether you be a man, a woman, another gender, a particular ethnic group or whatever, and just make certain that's reflected in the work that we do around cancer screening or vaccinating and do it that way around. So it's a kind of long-winded answer. I think the challenge is right, and maybe what we should reflect on then is when we report back on health inequalities and we say it needs to be everybody's business, it's asking everybody to show us the beef about what they've done to respond to health inequalities, challenges, whatever.
I'm thinking more of when the King came forward and said that he got prostate cancer, it made men be aware. So I'm just wondering how we can, you know, I'm glad that we're going in on women, but I'm just concerned that sometimes men, I say get away with it isn't the right word, is get away with having pressure put on them to say, right, you really need to go and have it checked or keep an eye on yourselves.
I think this doesn't mean we don't do anything for men. I mean, we have particular targeted approaches for like suicide, for, you know, getting the conversation started, that sort of thing. I think this is just a focus for this. And also, if you do focus on women, to be perfectly honest, if we can get the women going along various services, they're more likely to prod the men to go along, you know. But I get your point, Christine. I do get your point. Anyone else, Rachna?
Just to respond to some of that, when we did their prevention focus groups, the very huge populations of the responses we had back were, if you put in men's health hubs, there is no way that I'm going to go. However, if you put something on at the football club where I go every week, I'm more likely to access it because it's my peer group telling me that I should be doing something. So a lot of the work that we do with LCFC in the community, a lot of the work we do with the rugby club, with Leicester Riders, is focused more on that very targeted group of people. We have, of course, both sexes going to those types of events, but they've got some really targeted work going on with men. So it's not putting the label on it, which seemed to be the issue when we talk to big groups of men about the prevention strategy in the first place.
Anyone else? No? So thank you. We're asked to note the progress being made in relation to delivering against the staying healthy, safe and well priorities. Note the progress being made in relation to delivering against the reducing health inequalities cross-cutting priority. Are we all happy with that? Thank you. Thanks, Mike. The next item is the Integration Executive Joint Health and Wellbeing Strategy Progress Update, pages 419 to 450. Purpose of this report is to provide a progress update on the delivery of the living and supported well and dying well priorities of the Joint Health and Wellbeing Strategy. This report is being delivered by Tracy and Lisa presenting, is that correct? Thank you. And there's a PowerPoint presentation for this.
Thank you, Chair, and thank you for outlining the purpose of the report. So just in relation to the recommendation, the Health and Wellbeing Board is asked to note the progress in delivery of the Joint Health and Wellbeing Strategy priorities, which includes an update on the end of life development session. And obviously Kerry has presented a report in relation to the LLR strategy and the work that was undertaken in sessions on a county perspective back in March. And B is to note the additional plans for delivery of integrated services in 24-25. The policy framework and previous decisions are outlined in paragraphs 3 and 4 of your report. And just to give you some background information, the Integration Executives Work Programme was developed in 2022 to deliver against the Joint Health and Wellbeing Strategy life course priorities of living and supporting well and dying well. So the membership of the executive includes representation from Adult Social Care, Integrated Care Board, Public Health, Leicestershire Partnership Trust, the University Hospitals of Leicester, Health Watch, Districts and Boroughs and Primary Healthcare Services. Paragraphs 8 and 9 detail the two areas of the Joint Health and Wellbeing Strategy the Integration Executive is responsible for delivery against living and supporting well, as I alluded to, and dying well. It also sets out the priorities and the associated commitments. So moving on, just at paragraph 10, there's a set of slides to update the Health and Wellbeing Board on the progress against the delivery of the living and supporting well and dying well life course priorities. And it's attached to this report in Appendix A. Slides 3 and 4 show how the priorities within each of the life courses are being delivered by a series of agreed actions in the work programmes of the subgroups of the executive. This will take you through that presentation shortly. What I'd like to do is just highlight some of the areas where we can show delivery against some of those priorities. So within scaling up and prevention and self-care, the appendix shows that against these schemes listed, there have been in excess of 20,000 beneficiaries of these services. These range from advice and guidance, First Contact Plus, for example, to housing support services, the housing enablement team, and support to live long with long-term conditions related to the work of the care coordination work streams. Similarly, within effective management of frailty and complex care, there have been approximately 15,000 beneficiaries of services aligned to this priority, from supporting carers, the carer support service, to enablement service, the local authorities, home care assessment and enablement team, and from voluntary sector services, the RVS service around supporting people to be effectively discharged from hospital, and in relation to domiciliary care services. The Health and Wellbeing development session on Dying Well took place in March to highlight the challenges partners face in relation to supporting those experiencing end of life, and a previous mapping exercise was undertaken by the ICB. This highlighted potential gaps in areas that needed to be taken forward for delivery as an LLR partnership approach. Further work to build on this is needed and to maintain alignment of systems, place, neighbourhood working. The joint health and wellbeing strategy priority areas have been aligned to the LLR strategy and can be seen to be attached in the appendix that Lisa will present on. Key leads within adult social care have been aligned to these work streams to ensure join up of service delivery, and the ICB will provide regular updates to the integration exec on delivery of those work streams and priorities. So as well as the above, I'd like to advise you work taking place for with understanding need. Consultation with groups to understand effective care for individuals, their families and carers has begun. A joint strategic needs assessment element for end of life has also been developed to inform Leicestershire specific requirements. Within normalising end of life planning, shared care records are in development to aid joined up delivery of support services. The current joint and health and wellbeing strategy work programmes are delivered through two subgroups, the integration executive and the integration delivery group. And the joint commissioning and finance and performance group. As part of 24-25, the governance arrangements for the integration exec will alter slightly, with the IDG and JCG combining into one subgroup. That was identified because you can't really deliver without commissioning, or commission without the potential of delivery. So the reason behind this is to enable better engagement with partners. Often it's the same attendees at both of those groups, through one meeting where commissioning and delivery can be coordinated against one delivery plan instead of having separate plans. As you know from previous reports, the Integration Egg and its subgroup developed and refreshed the Better Care Fund plans, and we've had two reports in relation to those today. Regarding a forward plan, as part of the refresh of the BCF plan for 24-25, the following priorities will be areas to focus on for the next 12 months. So the delivery of Dying Well and that work stream, an options appraisal for discharge to assess bedded requirements, pilot a housing initiative supporting those with respiratory illnesses who are experiencing poor housing, further integrate the adaptation service with Lightbulb is one of the other priorities, increase the capacity in combined heart and crisis response service by a further 20% to look at supporting people to be effectively discharged to their own homes and receive appropriate reablement services, further work to use population health management data, increase training in integrated locality teams, and recommission training for the integrated personalised care framework. So just moving on, streamlining the governance of the integration exec, which I've alluded to, and developing the role of integrated neighbourhood teams. An updated delivery action plan will be brought back to the Health and Wellbeing Board in due course. And now I'm going to hand over to Lisa to take you through the presentation, which supports some of the content of the report.
Thank you. So largely what the presentation does is visualise quite a lot of what's in that kind of flat report there, because it's always good to be able to sort of see it as a diagram and as a visual. So on slide 2, we've got an overview of what the integration executive is about. On the left hand side, you can see what Tracy's told you, the partners that are involved in that delivery. The governance for the integration was made up of 2 subgroups for 23-24, the JCG and the IDG. Each subgroup has a work programme, and there's been a development session that we did in October 23 with the integration exec to look at how we make sure that we align those work programmes to our joint health and wellbeing strategy. Now, there's no prizes for being able to lead this. Kudos to you though if you can. So this is just a visual really to show you how we link our work plan for the IDG to the health and wellbeing priorities from the joint health and wellbeing strategy, the commitments, and how that translates into schemes, key activities, and we update against the current positions for each of those within those 2 boards. So that's for the IDG. And there's a very similar one, as you can see, for the JCG. They're also RAG rated, so we can tell at kind of a glance as to where we are with each of that activity. What influences our priorities? So it's not all about the BCF and all the joint health and wellbeing strategy. We also have influence from urgent emergency care, recovery plans, winter plans, adults and communities 10-year vision, and the list goes on. That's just a few of the things that actually help to influence our delivery and our decision making. So about the investment. So the investment largely, we've talked about this previously, is around the Better Care Fund. It's made up of several different elements. Those elements are listed there. We've been through them already as part of the 2 presentations that we've done on the BCF today, but that's just setting it out. For the 23-24 plan, I created this, which is a really good visual document to show you where our level of investment activity is and whether that's acute, intermediate or community and prevention. And when you look at how we actually balance, and I think Simon raised this point earlier, how we make sure we're doing that left shift of investment into the community and into intermediate care, that's where you can see this as a visual. So for example, 2.6 of our Better Care Fund, 2.6% is actually currently around funding acute care, with 25% in intermediate care and 72% in community and prevention services. So that gives you a really good idea about how we are trying to build that investment in the community and around intermediate care to actually try and ensure that we've got a stable acute environment by either preventing admissions and or reducing delays to people being discharged and making sure we've got demand and capacity in the right place. Living and supported well is the first part of the joint health and wellbeing strategy that the integration exec is responsible for delivering against. 2 priority areas: upscaling prevention and effective management of frailty and complex care. What I've done for each of these 2 priority areas is look at some of the activity. When I say some of the activity, there are currently 92 lines in the BCF of investment. So I've kind of gone out and cherry picked to make it look good for the presentation. So, so as Tracy said, there are loads of different areas where you've got multiple beneficiaries. For care coordinators, for example, they work on population health management data and risk stratified data for those people in the community who've got several long-term conditions, and work with them to have a care plan, work proactively rather than kind of waiting for that emergency admission. And we've had 7,307 of those, so that's quite a hefty amount. There's that falls data, Mike. Second line down. So with the amount of fallers in care homes, you can see as a flat rate of 50. When you look at the actual numbers, we've done a 15% reduction. So sometimes it is worth doing that bit of analysis to make sure that within falls, actually, we have done some really good work. Because that national data doesn't necessarily always reflect that, it is worth us being able to say, these are what we've done in terms of flat numbers. That is an LNR number, by the way. So roughly around 65% of that would be people in Leicestershire. We've got a DHU Falls car that works with Ageing Well funding, and we've had 834 beneficiaries. They will prevent admissions due to falls in the community. DFGs, 1,135 disabled facilities grants delivered across the districts, and primary care enhanced support. Within each of these, I've done the investment lines and I've linked the outcomes to it as well. The same applies for this slide as well. I won't necessarily go through each of them, but you can see here things like First Contact Plus, 5,716 beneficiaries, really good for the level of investment there. Housing enablement team, we've worked really hard to ensure that we have housing issues covered within hospital and mental health services, to make sure that people are discharged appropriately and supported well. 1,583, we've actually upped the investment of that, and we've had an improved percentage. I think they've done an extra 15% with the additional investment. So moving into community hospitals and psych wards, etc., so that we were able to cover more housing issues. This is effective management of frailty and complex care. You can see here our heart reablement team, 4,793 beneficiaries. We've got carer support services, home first teams, 3,540 people. Domiciliary care, one of our biggest spends, is 632,000 hours of care, and that's what we're investing in the community. We've got work from the Royal Voluntary Service in there as well, helping people at home when they've been discharged on a pathway 0, which is home with no additional support. This is the second slide on effective frailty and complex care. We've got interim support services in there as well that show that we've helped 1,091 people on a community response service. So that is our 2-hour response. Within Dying Well, you've had the presentation from Kerry. I wanted to show you how we're translating that now into the work of the integration exec. We've got 2 priority areas under Dying Well, which is understanding the need and normalising end-of-life planning. This slide shows you some of the key areas that we wanted to highlight from that development session. So we've got activity and actions that we're starting to work through. Slide 16 and 17, actually, I'll go on to show you how the JSNA and Joint Health and Wellbeing Strategy priorities are aligned to that LLR delivery that Kerry presented on earlier. Investments through the core health budgets, it's not through BCF. That's not to say it couldn't be in the future, but at the moment it's core health budgets. The priorities across LLR will be delivered through those 7 work streams. I've got a refresher slide on that. We are looking at working with VCS and community health and wellbeing plans. I think there are 3 at the moment, community health and wellbeing plans, that have got end of life as one of their key priorities. So we're making sure, like Kerry said, that we're actually linking in with those. We are looking at that Leicestershire mapping of activity and making sure that our dementia services are also engaged with the end-of-life support. There are those work streams that Kerry went through earlier. And what we've done here is we've taken the Joint Health and Wellbeing Strategy commitments and the key interventions that we're going to do to deliver those and which work stream they're going to fall under. What we didn't want to do is kind of have a disparate, unintegrated, perish the thought, response to end of life, where we had our Leicestershire work streams doing very similar work to other areas, particularly around things like engagement. Nobody wants 16, 17 different types of engagement. So we thought it was really important to make sure that we have a separate Leicestershire voice on that, and we recognise what we're going to be delivering, but we're doing it in conjunction with all our partners. This is the second slide that shows you that from a normalising end-of-life planning commitment. Moving on to some of the cross-cutting themes. So recognising that obviously we've got 3 cross-cutting themes within the Joint Health and Wellbeing Strategy. These are some of the things that we've been doing around improving mental health, and you can see again the investment there. For those, reducing health inequalities. There is some work that we intend to do in 24-25 to actually improve some of that system-wide development of BCF health inequalities work. So making sure that we've got standardised approach to equalities and quality within the BCF. These are some of the indicators about what we've achieved so far. I don't propose to go through them all, but some of these are really quite impressive so far. We've got an increase in heart reablement service capacity by 30%. We actually had a target of 50%, bless us, but we're 20% off, which we intend to do 24-25 with additional investment. But at the moment, we've upped the intake of heart reablement by 30%. What does that mean to people on the ground? If you think about the more people we get into heart, we hover around year on year, 90% of those people still being at home 90 days after receiving reablement. So the more people we get into reablement, the better it is for the person to maintain their independence. So that's why it matters. That's why we want to get as many people as we possibly can. There's that housing enablement team, 25% up they are, not 15%, I did them down. So we've further invested and they've increased their capacity by 25%. We've got a 35% decrease in residential care bed usage compared to 2022. That's directly from hospital and in the community for Step Up. 11% increase in the availability of packages of care to support discharge. That translates to an additional 15 plans a week. Improve wait times for plans in hospital. That's across the board for all of the 3 pathways that we're involved with. Don't ask me to quote them. They're in the back of my head somewhere. We've got a reduction in hip fractures. We've got a fully integrated heart and therapy locality team that we've been working on that I'm particularly proud of. So how does that translate to the person? So what we used to have within each community locality area was heart and therapy would work separately on the same people. And what we've done is we've recognised through some cross-training and daily MDTs, they will talk about each of those patients, and they've been trained to now deliver community equipment on behalf of each other, so that it reduces the duplication, it reduces the time spent, and it means that we've got a better outcome for the person. They're not having to wait longer extra days for equipment. They can get on with their reablement, and it means that we can reduce the amount of time that we spend with them as separate services as opposed to one service. And it's worked really well. Those teams are absolutely buzzing working together. They really enjoy it. They can thoroughly, every week they kind of say what's next. So now they're moving on to things like working with the district nursing teams, how to spot pressure sores, which means that they'll again be able to, with some cross training, be able to deliver some things that they haven't previously been able to do. So that's working really well. And then we've got the percentage of deaths occurred in hospital in Leicestershire was significantly below the percentage of England, which is 43%, against ours, which was 39.3%. Some of the challenges that we've faced, I think we all know there's been an increased demand. You've said it, Chair, in your position statement. There's been an increase in demand sort of post-COVID and beyond, really. Recruitment, Joe mentioned it, it is an issue across the board. We all struggling to recruit and to maintain staffing levels as we'd like them to be. Investment's not always easy because it's not always recurrent. We've got sort of £5 million worth of discharge grant, which is year on year, which is really difficult for us to invest then in recurrent staffing. We've got short-term demands, delaying our long-term planning often because we like to deal with the here and now. Market availability to increase care needs. Tracy mentioned earlier, we have a lot of people who now, with going into hospital presenting with behaviours, really difficult for us to place that sometimes in the residential care market, which means we're doing different things like looking at how we can procure high dependency beds. And then we've also got reduced training on healthcare tasks for care providers. We're in desperate need of making sure that we maintain the training levels as they are for those duplication of tasks. That reduces our workload for everybody, so it's massively beneficial. These are some of the things that Tracy's already gone through as our forward plan for 24-25. I won't propose to go through them again. But what have we gone through today? If there's anything that you take away, just to summarise, we've done an overview of the integration exec, our current governance and work plans, how things align to the joint health and wellbeing strategy priorities and commitments, work that we've kind of already completed for priorities or started to complete its priorities for 23-24, some of our key performance improvements, where we've got challenges and our forward plans.
Thank you. I have to say, I must thank all the subgroups. There's been a lot of movement and change, and to actually be coming forward and giving us the updates, I think is really important for the public to understand how much work is going on, and that it outlines how much partnership working is key to all of this. So thank you very much. Any questions or comments from anyone? Simon? Oh yes, Mike, please.
I'll repeat. Thank you. No, I have to say thank you, Tracy and Lisa, for an excellent presentation. And from a UHL perspective, the integration executive is a prime example of the system working together, and the system being the broadest way of describing it. We have many partners contributing to the integration executive, and the list of achievements is notable, none of which would have been achievable without Lisa's leadership over the last couple of years of that committee. So I think it's a real prime example of success. I think for the future challenges that we face, we have to keep on engaging in that subcommittee and working through some of those tricky issues. Sitting on that meeting myself, often we do have tricky issues to resolve, but it is by working collaboratively together as partners we solve them and deliver better outcomes for our population. So thank you to Lisa and Tracy.
Christine, was it?
Yeah, I mean, my battery's just gone. Thank you for the presentation. Can I just say, one of the things that I picked up on was more people are dying at home than dying in hospital. Is that because the ambulances didn't get to them in time to get them to hospital to be made better, or is it just, am I being sarcastic or nasty? I'm just wondering.
I will say, Christine, there are likely to be some people who die at home because they've had an acute episode related to their ill health. But the aim is to support people to die in their place of choice. So if I have a terminal illness and I don't want to die in hospital, the system will work with me, my family, my support networks to support me to go home and die.
Yes, because if anybody picked it up like I did, which is what I did, and the public might pick it up, but I think that's, I mean, I would rather die at home than in hospital, and I'm sure quite a lot of people would. So thank you for that explanation.
Sorry, I'll just take Mike.
Just to come in on that one, because I was trying to work out the same. And I get, if we were having a Rutland discussion, then from memory, it's a higher percentage of people who die at home in Rutland, but there is much less people that die in hospice care because there is no provision for hospice care. So I was rapidly working out the percentage in Leicestershire of those that die at home and those that die at hospital and compare it with England average. And if I've worked it out right, it's as near as damn it within 0.1%. So it's almost like we are the same in terms of people dying in hospices as the rest of the country. So that's a definite, you know what I mean? There's a definite shift from one to the other. It's not kind of massed. So, you know, there might be some care elements, but I think it's a genuine sense of more people are enabled to die in their preferred place in Leicestershire.
Thank you. So I know Lisa and Tracy glossed over this, but on that indicator slide, there is an inordinate amount of improved performance for the people of Leicestershire. So just to draw out the quality elements of this from an NHS perspective, we know that that 35% decrease in residential care bed usage, which we have worked really hard to get across health and social care, we know those people's outcomes are better. And we can't gloss over that. You know, there's a huge amount of change that we have to put in place to get some of this happening. The top quartile performance in reablement, you know, we're a big advocate on that heart service, only because we know, again, the longer term outcomes for those people are just better. So the investment that certainly from this Health and Wellbeing Board's perspective and the wider system across the integrated care system, that move towards reablement and the intermediate care model is absolutely the right thing. So in the midst of winter, when we've got ambulances queuing and we've got patients stacking up all over the place, that reablement model, we have to stick to our principles of that is the right thing to do for people, and therefore the investments that we put in, and I appreciate short-term funding, it's really difficult to do that, but that's what we're going to get that for the next couple of years. We're going to have to be really brave and stick to our guns, which we have done as a system previously. And I want to take the opportunity just to reiterate that point. We will be more than likely have to do that again, but it's the right thing to do.
Thank you, Rachna. Tracy.
Yeah, and Rachna knows the meetings that I sit in, how passionate I am about ensuring that when we can get people home following a hospital admission, that's what we'll seek to do. And I'm really proud that we've been able to do that. Where we do have to place people into residential care, I have a team of officers that work to try and support that person to have that stay in a residential care because it's required, but to get them home and to get them home with that reablement services. Reablement achieves, as Rachna said, really, really positive outcomes for the people that the service works for, but it also ensures that we've got an effective use of resources across the county for those people that need ongoing support and reduces the kind of financial burden on the taxpayer and the local authority.
I think it shows we do actually listen to our patients and residents and try and offer them what they want.
But I'd also like to say that we couldn't have done any of that with reablement if it hadn't been for our health and LPT and UHL colleagues. So UHL, for example, and LPT have both opened their doors to heart reablement teams working as part of an NDT, assessing people and making sure that we're maximising everybody that we can get into reablement. So without them and without LPT's support for therapy in the community, again, you can't do it alone.
And I think that's really, it's important to have all the partners around this table because it just shows how much work goes on between all of the different organisations. Anybody else? Okay, so we're asked to note the progress in delivery of the Joint Health and Wellbeing strategy priorities, which includes an update on the end-of-life development session, and note additional plans for delivery of integrated services in 24-25. All okay with that? Thank you. Final item. It's been a long meeting, but a really interesting one. This is the final item for discussion is the Health and Wellbeing Board Annual Report 23-24, which is pages 451 to 458. The purpose of this report is to provide the board with an outline proposal for producing the next annual report for 23-24. This report will be presented by Victoria Charlton, Health and Wellbeing Board Manager, and there's a PowerPoint presentation to this as well. Thank you, Victoria.
Thank you, Chair. I'll have to be really quick because my laptop's about to die and I can't lend you mine either. But yeah, very hard to follow all of that. What a fantastic agenda, and this seems very, very insignificant in comparison. But I just really wanted to talk through today quickly the approach to the annual report for 2023. It is just worth noting that the board, it's not a statutory requirement for the board to produce an annual report, but I think members have agreed and acknowledged that not only does it provide an opportunity to be transparent, but just provides that platform to update some of that good work that's happening, which obviously we've seen demonstrated today. So just going through some of those aims and objectives. So the annual report will cover the financial period of 23 and 24, and will also include updates and next steps for the forthcoming year. So that will be 24 and 25. It's anticipated that it's going to be presented at the September Health and Wellbeing Board for approval. And some of those key things that will be included in that will be a progress update on the statutory duties of the Health and Wellbeing Board, which includes the Joint Health and Wellbeing strategic priorities, the Better Care Fund, and also the Joint Strategic Need Assessments. And there'll also be a bit of an update on some of that wider work that's happening across place. And that will be examples of some of those projects and initiatives that sort of usually sit within the Do Sponsor Watch category. Where possible, we are going to include as many case studies and examples just to sort of demonstrate some of the achievements and the outcomes and just really sort of bring the annual report to life. There will be, as I said before, recommendations for the board to focus on for the next 12 months. And it's obviously important that the report will be widely accessible to our public and our partners as well. So just really in terms of the approach, it's intended that it's going to be an annual reporting cycle with every spring that the report will be produced, and then it will be presented at the subsequent summer, autumn Health and Wellbeing Board for approval. And that just gives enough time for the content to be produced over the summer. There is a project plan in place for this particular report, and that's just to support with delivery and ensure we stay on track. And it is intended that we'll use that as a bit of a template going forward for future rolling annual report programmes, and that will just help with forward planning. So contributions from our subgroups is going to be key, as well as our sort of partners and other Health and Wellbeing Board members, and that's just to ensure that we incorporate sort of the breadth of work that's happening across place. This really just quickly is the high level plan. So this just gives you a snapshot of some of those timelines and the deadlines we'll be working to over the summer. I won't go through every line in detail. You have got a copy in your packs, but just some dates just to really pick out. I have already met with our BI and comms colleagues just to give them oversight of this and ensure that it is incorporated into their work plan. But week commencing the 3rd of June, I will be meeting with subgroup leads and partners, and that's just to go through content expectations and some of those deadlines that we'll be working towards. And then between then and sort of middle of July, it'll be about getting those contributions in, reviewing them with the subgroups, going back, making any sort of tweaks, and then hopefully having any final amendments and versions sent to me by the 24th of July. That will be then produced into a summary report, which I'll share with you, Chair, for approval, and then that will be taken to the Health Overview and Scrutiny Committee for feedback. Any comments will then be incorporated into that final version, and then I'll bring that back to the September board for approval. Once approved, we'll be working with our comms and design team, and we'll get that formatted and sort of colourful and looking very nice, and then that should be ready for publication end of October. That's it, very quick. Brilliant.
That's
Right.
you both
Yes,
through that.
it did.
Yeah, thanks, Chair. Thanks, Victoria. Can we give some thought over summer for discussion when we see it in September about what we then do with it? Because I just have a feeling if it's based on what we've heard today, there's going to be so much good stuff that we would want to share with the public, not just to then badge everything as being what the Health and Wellbeing Board's done, but even if you recognise it as being the work of individual partner organisations within the HWPB, it seems a bit of a shame to kind of say we'll publish it and we'll take it to scrutiny. And I just wonder if there's anything we can do around media and comms to push it out there. Could this be something we could flag in Leicestershire Matters and just direct people towards something like that? So unless you've got the comms plan already in your mind, then I just think there's something about, not just congratulating ourselves on what we've done.
I think it's really important, and I think, the amount of work that's being done by all partners, I think it's really important to get that out into the public domain and make sure people understand. Yes, Rachel.
Thank you, Victoria. One thing that's come back through a lot of our engagement is the value of the case studies about, what people are at, so what? So 30% extra, whatever means what for people. I think that's the power of some of this stuff. And I think if we could do something, as Mike said, we need to do something with it, particularly with social media and that kind of stuff, short videos and those types of things. Not that I'm trying to add work to anything, but, if we're going to really engage with people about the work and get them to engage back with us, this is a great opportunity, isn't it?
Yeah, I'd also like to just put my personal plea out there, because this is a lot of work on one person. So if subgroups and partners can work as much as they can to the timelines, it would really help. And I think it's up to us all. We want to present to the public what is happening between all of us. So we all have to take a joint commitment to this. Thank you. So any questions otherwise? Oh, yeah.
When you say work for one person, I'm looking at the officers to contact and it says Mike Sands or Josh Namavji. I hope you don't mean either of them.
So So we're asked to approve the proposed approach for producing the Health and Wellbeing Annual Report for 23-24. We're all right with that. Thank you very much. Date of the next meeting of the board will be Thursday, 26th of September at 2 o'clock. So I do hope we can all attend, and some of our, missing people, I hope they'll come along next time. There are no other items that I've decided to take as urgent. So that concludes the meeting. Thank you to all of you and all of the officers and presenters today. I think it's been a long agenda, but it's been a really interesting one. So thank you all for your input. And that concludes the meeting.